Good evening, welcome to Rest Academy. In this session, you'll get a gentle 2-hour foundations class in medicine. Where do doctors begin? How do systems connect? And how does a single drop of blood carrying millions of red cells already hint at answers? During this video, you'll relax while absorbing core clinical science in one calm flow. To make this journey complete, I've prepared a free practical guide with a concise summary of tonight's lesson, waiting in the description like a map you can return to whenever needed. Let's begin. Night settles and the room is cool. Your breathing evens out as you let your attention narrow to a single task, learning medicine the way clinicians do, slowly, methodically, kindly. You will use this class as a structured lullaby of facts, not instructions. That distinction matters. Education explains how bodies work and how clinicians reason. Advice tells you what you personally should do. This is education only. If you experience worrisome symptoms like crushing chest discomfort, severe shortness of breath, sudden weakness in a limb, or a rapidly worsening fever, you seek professional care. Education never replaces evaluation. You'll move through a consistent rhythm: idea, mechanism, example. Idea means the core concept stated simply. Mechanism means how it functions inside the body, from molecules to organs. Example means a small anonymous vignette to anchor, meaning while staying general. The cadence is slow on purpose because your nervous system settles with predictability. Predictability here is a design choice, not a sedative. Think of this class as a quiet observatory. The observatory is your mind, dark, adapted, and calm. Through the telescope you watch reliable motions, cells exchanging signals, organs sharing load, systems correcting drift. You adjust the focus ring, definitions first, then zoom to see relationships. You'll keep that single metaphor throughout, a lens that sharpens without rushing. 2 safety rails guide the path. The first rail is scope. You learn what terms mean and how clinicians connect them, but you do not practice on yourself or others. No dosing, no regimens, no self-directed treatments. The second rail is uncertainty. Medicine handles probabilities, not certainties, because bodies vary and contexts differ. You will hear words like likelihood, tendency, and pattern. They are not hedges, they are honest reflections of complex biology. Start with listening. Listening is an active clinical skill, and you'll practice it by listening to the material. In medicine, listening begins before words: breath rate, posture, cadence. Here, listening means you notice your own state, if your jaw softens, if your shoulders drop, if your mind drifts. Drifting is allowed. The structure is layered so you can rejoin at any point without losing the thread. Each section stands alone yet links to the next. The plan spans 22 sections, roughly 2 hours at a gentle pace. You begin with how to use the class, then climb from microscopic to macroscopic organization, cell to tissue to organ to system, before learning how clinicians think. You'll collect the building blocks of a clinical conversation: history, exam, vital signs, and initial labs. Then you'll widen to imaging and core physiology: cardiac, respiratory, renal, neuro, endocrine, and gastrointestinal, before touching pharmacology, microbiology, and the logic of evidence. Finally, you'll integrate 3 brief cases to see the pieces align without strain. Because sleep is one of biology's most powerful regulators, a word about it belongs here. Sleep architecture refers to the structured cycles your brain moves through at night. While you listen, your thalamus, the relay hub that filters sensory input, reduces non-salient noise, and the autonomic nervous system tilts toward parasympathetic tone, the branch that promotes rest and digestion. You'll notice slower heart rate and steadier breathing. This physiologic shift helps consolidate facts into memory traces without effort. You are not forcing recall, you are allowing it. Terminology will be defined at first mention. When you hear homeostasis, you'll learn it means the body's tendency to maintain internal stability, temperature, pH, fluid balance through coordinated feedback loops. When you hear set point, you'll learn it means the target around which those systems hover, like the temperature a thermostat aims to keep. When you hear probabilistic thinking, you'll learn it means updating your belief about a diagnosis as new data arrive, akin to refining a weather forecast. Plain words first, refined nuance later. What if technical language feels heavy? You diffuse the load by tethering each term to one image and one use. Example preload is how much the heart fills before it contracts. Picture a spring gently compressed, more fill, more stretch, more recoil, up to a physiologic limit. Example sensitivity and specificity are test characteristics. Sensitivity asks, among people who truly have the condition, how many test positive. Specificity asks, among those who don't, how many test negative. These definitions are short because clarity reduces effort and effort fights sleep. Here is how to position yourself for learning. Choose a comfortable posture where your neck is neutral and your chest can expand. Keep a stable, quiet background. If your mind offers intrusive worries, label them briefly, planning, remembering, judging, then return to the next sentence. The label is not a cure, it's a handle that lets you set the thought down without argument. You'll also hear brief clinical vignettes. They are composites, no personal details, no identifying features, used to illustrate reasoning only. Each vignette will include one concern cue, something that would prompt seeking care, so you can feel how clinicians separate routine signals from urgent ones. Again, this is not to make you your own clinician, it is to demystify the logic. A note on disagreement. Medicine evolves. Some thresholds and preferred terms shift as studies accumulate. When uncertainty exists, you'll hear it named. For example, normal ranges can vary by lab method, population, and context. You will learn to treat a number as one clue, not a verdict. That habit protects against overconfidence and underattention alike. The metaphor of the observatory returns. Each concept is a star, constellations are systems, the turning sky is physiology in motion. You do not rush to capture every point. You trace a few lines at a time until patterns settle. If you fall asleep and wake later, you simply pick up the next pattern, the sky is still there. Before you step into the structure of life from cell to system, one last orientation. Compassion is a clinical skill. It changes how data are gathered and interpreted. When clinicians assume good intent, reflect emotion neutrally, and validate experience, they uncover better histories and safer plans. You can borrow that stance toward yourself while listening. If fatigue surfaces, you acknowledge it. If curiosity sparks, you follow it lightly. You're ready. The telescope is balanced. The dome is quiet. The first star is rising. You will now watch how the smallest units of life combine into tissues, organs, and systems that correct their own drift. What holds a body steady when everything inside it is moving, and how does that steadiness quietly fail and recover? You stand at the shoreline of a branching delta and watch streams merge into a widening river. That is the body's plan, small currents joining to form larger flows. A cell is the smallest unit that carries life's instructions and maintains its own boundary. Its membrane is a selective barrier built from lipids and proteins. It lets ions and molecules pass by rules, channels, carriers, pumps, so the inner fluid stays different from the outside. Difference is the point. Gradients store potential energy, and life spends that potential carefully. Cells do specialized work. Neurons transmit signals, myocytes generate force, epithelial cells line and protect, immune cells survey and respond. When similar cells join, they form tissues, coherent pieces with shared tasks. 4 broad tissue classes frame most structures. Epithelial tissue lines surfaces and glands, controlling exchange. Connective tissue provides support and transport from tendons to blood. Muscle tissue creates movement, skeletal, cardiac, smooth. Nervous tissue gathers, processes, and routes information. You will see the same motifs: barrier, support, motion, signaling, recur at higher scales. Organs combine multiple tissues to accomplish a defined function. The stomach mixes and digests. The kidney filters and reclaims. The lung exchanges gases. Organ systems coordinate across distance to meet the organism's needs. The cardiovascular system moves nutrients and heat. The respiratory system handles oxygen and carbon dioxide. The renal system shapes fluid and electrolytes. The endocrine system broadcasts chemical messages. The nervous system orchestrates rapid control. Like tributaries, each system flows into the same river, stable internal conditions despite changing surroundings. That steadiness is homeostasis. Homeostasis means maintaining internal variables within tolerable ranges using feedback control. 3 pieces define a homeostatic loop. A sensor detects deviation, an integrator compares current value to a target, and an effector shifts the variable back toward the target. Negative feedback responses that oppose the drift is the dominant pattern. A set point is the target the integrator aims for. Crucially, set points are not single magic numbers. They are flexible zones that shift with context. Sleep, stress, exercise, illness, pregnancy, and circadian phase can move them. Consider body temperature. Specialized neurons in the hypothalamus sample blood temperature, and skin thermoreceptors report ambient change. When core temperature drifts below the set point, effectors engage. Skeletal muscles shiver to generate heat. Skin blood vessels constrict to reduce heat loss. Behavior alters, seeking warmth, changing posture. When temperature rises, sweat glands increase evaporation, and skin blood vessels dilate to shed heat. The point is not perfect constancy, it is dynamic correction. During the day, your temperature set point tends to run slightly higher than at night, and illness can raise it further. Adaptive shifts that support immune function. Glucose control illustrates hormonal cooperation. After you eat, blood glucose rises. Pancreatic beta cells sense this and release insulin, a hormone that promotes uptake of glucose into muscle and fat, while encouraging the liver to store excess as glycogen. Between meals or during exertion, pancreatic alpha cells release glucagon, which signals the liver to free stored glucose. The brain depends on a steady glucose supply. These paired signals smooth bumps in the road. Stress hormones can temporarily raise glucose. Sleep curtailment nudges regulation less efficient. Circadian timing modulates sensitivity. Again, set points breathe with context. Fluid and sodium balance show how multiple systems share one problem. Osmoreceptors in the hypothalamus detect plasma concentration. If fluids are too concentrated, the posterior pituitary releases antidiuretic hormone, which tells the kidney to reclaim water. Thirst intensifies, guiding behavior. If circulating volume falls, sensors in the kidney and blood vessels trigger the renin-angiotensin-aldosterone axis, which raises vascular tone and encourages sodium and water retention. The kidney is the final common pathway. What enters the tubules can be reclaimed or allowed to pass out. Your blood pressure is a downstream readout of this regulation, sensitive to volume, vessel tone, and cardiac output. Acid-base control protects proteins from denaturing. Cellular metabolism produces acids. Ventilation and renal handling keep pH within a narrow band by moving carbon dioxide and bicarbonate in coordinated fashion. Sensors in the brainstem respond to carbon dioxide. If carbon dioxide rises, ventilation increases to blow it off. The kidney adjusts slower but more durably by reclaiming bicarbonate and excreting acids. Buffers within blood and cells provide immediate short-term stabilization. You will later learn a structured way to read these signals in an arterial blood gas. For now, see the pattern: fast respiratory correction, slower renal correction, both aiming at stability. Why does any of this matter to clinical reasoning? Because symptoms often signal perturbations in these loops. Lightheadedness can reflect low circulating volume, reduced heart output, or inappropriate vessel dilation. Fatigue can reflect low oxygen delivery, altered thyroid set points, inflammatory signaling, or sleep deprivation's impact on neural networks. The task is to map a symptom to the most plausible loops that could generate it, and then ask targeted questions that narrow the map. The VIR image helps. Imagine tributaries carrying heat, oxygen, glucose, and ions toward the main channel of whole body stability. A sandbar forms when one tributary slows or overflows. You do not need to rebuild the river, you look upstream. Is the sensor misreading? Is the integrator's target shifted? Is the effector blocked? A fever shifts the temperature set point upward. In that case, shivering at a normal measured temperature can still be perfectly coherent because the body's target has moved. Coherence, not comfort, explains the response. A small vignette: you meet an adult who reports profound thirst, frequent urination, and fatigue over days. Their mouth is dry, their heart rate is fast, their breathing is deeper than usual. You think through loops. Thirst and urination point to water balance and glucose control. Deep breathing can be a compensatory response to an acid load. You do not diagnose here, but you recognize a pattern that could reflect serious metabolic disturbance. The concern cue is the combination thirst plus excessive urination plus altered breathing, especially if accompanied by abdominal pain or confusion. That pattern warrants urgent clinical evaluation. 2 refinements add nuance. First, allostasis describes stability through change, set points that adapt to predicted demands. Training in heat raises sweating efficiency. Altitude acclimatization increases ventilation and red cell production over days. Pregnancy shifts volume and vascular tone to support placental flow. Second, redundancy matters. Multiple effectors can correct the same deviation. Temperature uses behavior, skin vessels, sweat, and muscle. Blood pressure uses heart rate, stroke volume, vessel tone, and volume. Redundancy adds resilience but also complexity when loops crosstalk. Homeostasis has limits. If challenges exceed capacity or persist too long, corrections can overshoot or fail. In sepsis, inflammatory signals dilate vessels and leak fluid from the vascular space, dropping effective volume even when total body water is high. The integrator's comparisons lose accuracy amid noisy inputs, and effectors cannot restore pressure alone. In chronic lung disease, the respiratory controller may reset to tolerate higher carbon dioxide, shifting the relationship between ventilation and gas levels. Recognizing these limit states prevents simplistic expectations of normal. You can let the idea settle that your body is a living control system with wise flexibility. Instead of demanding constancy, it prefers patterned adjustment. Naming the pattern quiets anxiety. Variation is often design, not failure. One line settles the concept. The river is stable not because water is still, but because flow is managed. You are ready to watch how clinicians use this map when a single symptom appears on the horizon. What paths do they test first, and how do they avoid the traps of assumption? You may picture a dimly lit consultation room where silence fills the air after you mention a troubling symptom. The physician does not answer immediately. Instead, they begin a quiet internal process. What exactly is happening in that pause? The physician's thinking follows a path that combines structure with constant uncertainty. They start by identifying the symptom, a subjective experience you report, such as chest discomfort or dizziness. Then they generate a differential diagnosis, a list of possible causes ranked by likelihood. This is not a guess, but a probabilistic exercise grounded in epidemiology and clinical experience. Probability matters because medicine is never absolute. The same symptom could represent a benign condition or a life-threatening emergency. For example, chest pain might arise from simple reflux or from acute coronary syndrome. The physician weighs base rates, how common each condition is in your demographic, against the details of your case. Biases influence this reasoning. Anchoring bias occurs when the first impression dominates, even after new evidence arrives. Confirmation bias tempts one to seek only information that supports an early hypothesis. Physicians are trained to recognize and counteract these patterns, often by deliberately asking themselves, what else could this be, or using structured checklists. The process resembles detective work with shifting clues. A patient reports cough. The doctor considers infection, asthma, or heart failure. Each additional piece of data, duration, sputum color, smoking history, changes the weight of possibilities. Here Bayesian reasoning is implicit, prior probability updated by new evidence. This way of thinking extends beyond the clinic. It explains why diagnostic error remains a risk and why second opinions can be valuable. If a person experiences persistent symptoms that do not improve, the responsible action is to seek reevaluation by another professional. Imagine a resident physician on a night shift. A patient arrives with fever and confusion. The resident's first thought is urinary infection, common in older adults, but the vital signs show low blood pressure and rapid breathing. The supervisor encourages the resident to broaden the frame. Could this be sepsis, pneumonia, even meningitis? The reminder prevents a narrow focus and potentially saves a life. The physician's thought process teaches you patience with ambiguity. Even experts live with uncertainty, and progress emerges not from perfect answers, but from disciplined questioning. And yet, if medical reasoning is always probabilistic, how do doctors gather the raw material to fuel these hypotheses? That takes us to the next step, the structured history. The room becomes a stage where words carry diagnostic weight. You sit, and the physician begins not with machines or tests, but with questions. This process is called history-taking, and it remains the foundation of clinical medicine. Up to 3/4 of diagnoses can be suspected or even made from history alone. The tools are not stethoscopes or scanners, but structured listening and careful sequencing. The first element is the chief concern. This is your own phrasing of why you sought care. I have crushing pain in my chest, or I am unusually tired. Physicians do not reword this into jargon at first. They keep it in your voice as it anchors the consultation. The second element is the history of present illness, often abbreviated HPI. Here details matter: onset, duration, intensity, progression, relieving and aggravating factors, associated symptoms. Clinicians may use mnemonics like old carts, onset, location, duration, character, aggravating/relieving, timing, severity, not to reduce you to checkboxes, but to ensure no thread is missed. Past medical history follows. This catalogs chronic conditions, surgeries, or significant events that may color the present complaint. Medications are listed next, including prescription drugs, over-the-counter agents, and supplements. Each can interact with physiology or mask clues. Allergies are asked about with precision. The reaction type matters: rash, swelling, anaphylaxis, because true allergies differ from mild intolerance. Family history contributes patterns: heart disease in relatives, autoimmune conditions, cancers with hereditary tendencies. Social history maps lifestyle influences: tobacco, alcohol, occupation, sleep habits, and contextual stressors that shape health outcomes. Communication style makes the difference between rote data collection and empathetic connection. Physicians are trained to use open-ended questions first. Tell me more about the pain, then narrow with specifics. Eye contact, pauses, and non-judgmental listening encourage disclosure. Empathy here is not sentimental but functional. When patients feel heard, the accuracy of the information improves. Consider an example. A young adult reports abdominal pain. If the physician interrupts too soon, they may miss that the pain began after antibiotic use and is accompanied by watery diarrhea, details suggesting infection. If the physician listens fully, patterns emerge that align with possible causes, guiding the next steps efficiently. The structure is also a safety net. Suppose a patient arrives short of breath. Without structure, the story might circle around fatigue. With structure, the clinician asks about smoking history, occupational exposures, travel, swelling in the legs, fevers. Each piece broadens the view and prevents tunnel vision. The structured interview is therefore a diagnostic test in itself, with sensitivity and specificity improved by practice. At times, red flags appear in history alone. Severe chest pain radiating to the jaw, sudden neurological deficit, or unexplained bleeding are cues for immediate escalation. Recognizing these patterns is less about memorizing lists and more about understanding the physiology: blocked arteries, interrupted brain flow, impaired clotting. If a listener notices such symptoms in real life, the correct response is not self-analysis, but urgent professional evaluation. History-taking also teaches humility. A physician may form a hypothesis early, but every new answer is a chance to update. The temptation to cling to an initial story is strong, yet safety lies in flexibility. A careful history reminds us that patients often tell you the diagnosis if you truly listen. In your own life, structured listening can be a calming practice. When someone speaks, resist the urge to finish their thought. Let their narrative breathe. The missing details often reveal the core truth. Now the history provides a map, but a map must be validated by terrain. What does the body itself reveal when carefully examined? That is where the physical exam begins. The light in the room shifts as the physician sets aside the notebook and turns attention to the body itself. The physical exam is not about theatrics. It is a disciplined sequence of observations and gentle maneuvers that reveal how systems are functioning in real time. It begins not with touch, but with sight. Inspection is the first step. The clinician observes posture, facial expression, skin color, breathing pattern. The eyes can reveal jaundice, the skin may show rashes or bruises, the nails can display clubbing that suggests chronic lung disease. Even the way you walk into the room or rise from a chair offers diagnostic data. These visual impressions may appear subtle, but they are trained signals that orient the rest of the exam. Palpation follows. This is the use of hands to assess texture, tenderness, temperature, or underlying structures. A physician may palpate lymph nodes in the neck, checking for enlargement, feel the abdomen for masses or organ size, or press gently on the chest wall to distinguish muscle pain from deeper causes. In cardiovascular exam, palpating pulses at wrists, ankles, and neck helps gauge circulation. Next comes percussion. The examiner taps lightly on the body surface and listens to the sound produced. A hollow resonant note suggests air-filled lungs. A dull note suggests fluid or solid tissue. Percussion of the chest can detect pleural effusion. Percussion of the abdomen can outline the liver or detect fluid accumulation. It is an ancient technique, but still provides rapid bedside insights without machines. Auscultation is listening, usually with a stethoscope. Over the heart, it reveals rhythm, extra sounds, or murmurs that suggest valve disease. Over the lungs, it distinguishes normal breath sounds from wheezes, crackles, or absent air entry. Over the abdomen, it can capture bowel activity. The stethoscope amplifies these vibrations, but the ear interprets them through training and pattern recognition. Regional exams combine these techniques. In the cardiovascular system, inspection may reveal jugular venous distension, palpation checks for peripheral edema, auscultation identifies murmurs. In the respiratory system, inspection shows chest expansion, percussion maps resonance, auscultation confirms airflow. In the abdomen, inspection finds scars or distension, palpation tests for tenderness, percussion estimates organ size, auscultation listens for bowel sounds. Neurological exams layer additional tools, reflex hammers, tuning forks, light touch, and coordination tasks. The sequence matters because each step builds on the previous. You cannot interpret an abnormal sound without knowing the visual context. You cannot judge tenderness without first inspecting for inflammation. The exam is like reading a layered manuscript. Each page deepens the meaning of the last. A short vignette illustrates the value. A patient complains of shortness of breath. On inspection, the physician sees labored breathing. Palpation shows reduced chest expansion on one side. Percussion is dull over the lower right lung field. Auscultation reveals absent breath sounds there. The integration points toward pleural effusion, fluid compressing the lung. Without imaging, the exam already narrows the possibilities. But there are also safety signals to catch. If palpation of the abdomen reveals rigidity with severe pain, that suggests peritonitis, a surgical emergency. If auscultation of the lungs reveals stridor, a harsh sound during inspiration, airway obstruction may be imminent. In such cases, the physical exam becomes not just descriptive but urgent, prompting immediate professional action. Physical exam skills decline if unused, yet they remain essential. Imaging and laboratory tools are powerful, but they cannot replace the immediacy of touch and observation. A skilled exam can shorten the diagnostic path, prevent unnecessary tests, and build trust. The act of laying hands gently conveys presence. Patients often report feeling more cared for when examined thoroughly. To observe closely and without haste is itself a discipline. When you give attention to the small details in the body, in a conversation, in your own environment, you discover patterns that guide wiser choices. From the body's visible signs, attention turns next to the body's core measurements. These vital signs are the numeric fingerprints of physiology, and they tell their own quiet story. 5 numbers, sometimes 6, can sketch a living portrait in less than a minute. These are vital signs, core measurements that capture how well fundamental systems are performing. They are called vital, not because they predict everything, but because they track functions without which life cannot persist. Each sign reflects a balance point between demand and capacity. Blood pressure comes first. It is the force of blood against vessel walls, recorded as systolic, peak during contraction, over diastolic, rest between beats. A sphygmomanometer cuff inflates to stop flow, then releases gradually while sounds are heard or pulses felt. Proper technique matters. The cuff size must fit the arm. The patient should be seated and the arm supported at heart level. Too small a cuff or hurried measurement can mislead. Low pressure may signal dehydration, bleeding, or sepsis. High pressure may reflect chronic vascular load or acute stress. The context, fainting, chest pain, stroke symptoms dictates urgency. Heart rate or pulse is next. It reflects cardiac cycles per minute, felt at arteries like the radial at the wrist or carotid in the neck. A normal rhythm is steady, but sometimes irregularity appears, such as atrial fibrillation where the beat seems chaotic. A racing pulse at rest may reflect fever, anemia, pain, or heart strain. A pulse too slow may reflect athletic conditioning, drug effects, or conduction disease. Rate, rhythm, and strength together paint a fuller picture than a number alone. Respiratory rate is the quietest sign yet, often the earliest to change. It is simply breaths per minute, counted discreetly without telling the patient, since conscious control can alter it. Fast breathing can occur with fever, pain, anxiety, or metabolic acidosis. Slow or shallow breathing may follow drug effects or neurological injury. The rhythm, depth, and use of accessory muscles matter as much as the count. Temperature indicates the body's thermal state. Oral, tympanic, axillary, and rectal methods differ in accuracy. Normal values shift slightly with circadian rhythm, lowest before dawn and highest in late afternoon. Fever reflects set point elevation by inflammatory signals, while hypothermia may result from exposure, endocrine failure, or sepsis. Technique and context again shape interpretation. Oxygen saturation, measured by pulse oximetry, estimates how much hemoglobin is carrying oxygen. A probe on the finger, ear, or forehead shines light through tissue and analyzes absorption. Normal ranges are high, but values drop in lung disease, circulatory shock, or airway obstruction. Nail polish, cold fingers, or poor circulation can produce false readings. Trends over time are often more informative than single numbers. Some clinicians also add pain score as a fifth vital sign, but it differs. It is subjective, not directly measurable. Still, tracking pain matters because it guides comfort and reveals underlying pathology. A brief clinical sketch shows how vital signs orient action. A patient arrives with dizziness. Blood pressure is 85/55, heart rate 120, respiratory rate 26, temperature 38.5, oxygen saturation 91%. Each number points toward instability, low pressure, rapid heart, fast breathing, fever, and hypoxemia. Together they suggest possible infection with circulatory compromise, sepsis. Without these signs, the dizziness might seem trivial. With them, urgency is clear. Red flags and vital signs include very low blood pressure with altered consciousness, very high pressure with neurological deficits, heart rate extremes, LEM 40 or 150 at rest, respiratory rate above 30, oxygen saturation below 90% despite air, or body temperature dangerously low or high. Such readings warrant immediate professional evaluation. Yet vital signs also teach subtlety. A mildly elevated heart rate may simply reflect anxiety. A single fever reading may reflect exercise, warm clothing, or hormonal cycle. Interpretation requires context, repetition, and correlation with the overall picture. In your own awareness, you can view breath, pulse, and warmth as signals rather than distractions. Observed calmly, they remind you that the body is a responsive system, adjusting continuously to keep you safe. The numbers form a framework. Next comes the laboratory window, where blood cells tell their story and reveal hidden imbalances. A vial of blood, red against the glass, contains a coded history of production, circulation, and immune response. The complete blood count, or hemogram, is one of the most common laboratory tests, yet its numbers reveal much when read in sequence. Hemoglobin is the protein that carries oxygen in red blood cells. Its concentration indicates the capacity of blood to transport oxygen. Hematocrit is the proportion of blood volume occupied by red cells. It reflects similar information, but from a volume perspective. Mean corpuscular volume, or MCV, describes the average size of red cells. Together, these three markers can hint at different kinds of anemia, the condition of reduced oxygen carrying capacity. If hemoglobin is low and MCV is small, microcytic anemia is suspected, often linked to iron deficiency or chronic disease. If cells are large, macrocytic anemia suggests vitamin B12 or folate deficiency, or certain marrow conditions. If cells are normal in size but fewer in number, blood loss or marrow suppression may be the cause. Thus the pattern is more revealing than any single value. Platelets. The small cell fragments that help blood clot are also counted. Low platelets may occur with bone marrow suppression, immune destruction, or consumption in severe illness. High platelets may reflect inflammation or a bone marrow disorder. Either extreme can increase bleeding or clotting risks. White blood cells form the immune army. The total count offers a rough gauge of activity, but the differential proportions of neutrophils, lymphocytes, monocytes, eosinophils, basophils provides nuance. A rise in neutrophils often indicates bacterial infection or stress. More lymphocytes suggest viral illness. Eosinophilia points to allergy or parasitic infection. The mix tells a story of the immune system's current battle. Interpretation requires caution. A mild rise in white cells after exercise or stress may be normal. Platelet counts can fluctuate with hydration or menstruation. Anemia can result from nutritional deficiency, chronic disease, or acute bleeding. No number alone makes the diagnosis. The context of history and exam determines significance. Consider a vignette. A patient presents with fatigue. The hemogram shows hemoglobin low, hematocrit reduced, MCV small. Further history reveals heavy menstrual bleeding. The pattern supports iron deficiency anemia, a common but important condition. The red flag is fatigue severe enough to impair daily life, or associated symptoms like chest pain or shortness of breath. Such cases call for timely medical evaluation. Mechanistically, the bone marrow produces millions of cells per second. Stem cells differentiate into red cells, white cells, and platelets under hormonal signals like erythropoietin. When nutrients or marrow function falter, output declines. Conversely, infection or inflammation can accelerate production. The hemogram is therefore a snapshot of marrow health, nutrient status, and immune activity. You may notice how each number gains meaning only in relation to others. This principle applies beyond blood. Understanding emerges from patterns, not isolated facts. With the blood's cellular story introduced, attention next turns to the chemistry of plasma and the simple but revealing test of urine, windows into metabolism, kidney and liver function. A clear tube of plasma and a small cup of urine can speak volumes about internal chemistry. These tests examine the dissolved molecules that circulate and are excreted, complementing the cellular story told by the hemogram. Together, they outline how organs manage balance, energy, and waste. Electrolytes come first. Sodium is the primary extracellular ion, vital for water distribution and nerve transmission. Abnormal sodium can cause confusion, seizures, or lethargy, depending on whether it is too low, hyponatremia, or too high, hypernatremia. Potassium, largely inside cells, influences muscle and heart function. Too much potassium risks dangerous arrhythmias. Too little can cause weakness or rhythm disturbances as well. Chloride often moves with sodium, maintaining electrical neutrality, while bicarbonate reflects acid-base balance. Renal function is gauged by urea and creatinine. Urea arises from protein metabolism, creatinine from muscle breakdown. Both are filtered by the kidney. Elevated levels suggest impaired clearance, but they can also rise with dehydration or high protein intake. Estimated glomerular filtration rate derived from creatinine and demographic factors provides a practical measure of kidney filtering capacity. Liver function tests survey enzymes and proteins. Alanine aminotransferase ALT and aspartate aminotransferase AST rise when liver cells are injured. Alkaline phosphatase ALP rises with bile duct obstruction or bone turnover. Bilirubin, a breakdown product of hemoglobin, accumulates when liver processing or bile flow is impaired, sometimes visible as jaundice. Albumin and clotting factors reflect synthetic capacity, the liver's ability to make essential proteins. Glucose testing assesses energy balance. Fasting glucose and longer-term markers such as glycated hemoglobin indicate how well the body regulates sugar. High glucose may point toward diabetes or stress responses. Low glucose can cause sweating, confusion, even seizures. The context of meals, medications, and stress hormones matters for interpretation. Urine testing adds another dimension. A dipstick can quickly detect protein, glucose, blood, nitrites, and pH. Protein in urine may signal kidney disease. Glucose suggests high blood sugar exceeding reabsorption capacity. Blood may indicate infection, stones, or trauma. Microscopic examination can reveal casts, cylindrical structures formed in kidney tubules that hint at specific pathologies. Color and clarity also carry meaning, from dark brown in severe liver disease to red in hematuria. A clinical sketch illustrates integration. A patient reports swelling in the ankles. Blood chemistry shows low albumin, suggesting reduced protein synthesis. Urine dipstick reveals protein leakage. Together, these findings point toward nephrotic syndrome, a kidney disorder where protein is lost excessively. The red flag here is swelling with sudden weight gain and frothy urine, a constellation warranting professional evaluation. Mechanistically, these molecules reflect constant turnover. Electrolytes move through channels and pumps, guided by hormones such as aldosterone and antidiuretic hormone. The kidney filters plasma continuously, reclaiming needed substances and excreting waste. The liver processes nutrients, detoxifies chemicals, and produces proteins. Glucose is managed by the interplay of insulin, glucagon, cortisol, and growth hormone. Each lab result is a glimpse into these dynamic exchanges. The idea that a few milliliters of fluid can summarize whole body balance invites respect. Small samples can reveal vast processes, much like a single paragraph can outline an entire story. Chemistry and urine give static points, but sometimes what matters is not static but dynamic, the balance between acids and bases in the blood. That is the task of arterial blood gases. The next chapter, a syringe of bright red blood, drawn from an artery rather than a vein, holds a precise record of how lungs, kidneys, and metabolism interact in real time. This is the arterial blood gas, often abbreviated ABG. Its interpretation can feel intimidating, but when approached step by step, it becomes a logical dialogue among body systems. The first variable is pH, a measure of acidity or alkalinity. Normal blood pH is tightly regulated near neutrality because enzymes, membranes, and proteins depend on it. A fall in pH indicates acidosis. A rise indicates alkalosis. The question is always, is the disturbance respiratory, metabolic, or a mixture? Carbon dioxide PiCO2 is next. It represents the respiratory component. The lungs remove CO2 with each breath, so high PiCO2 means hypoventilation, inadequate removal, producing respiratory acidosis. Low PiCO2 means hypoventilation, excessive removal, producing respiratory alkalosis. Bicarbonate, HCO3 numbing, is the metabolic component. The kidneys reabsorb filtered bicarbonate and generate new bicarbonate to buffer acids. Low bicarbonate suggests metabolic acidosis. High bicarbonate suggests metabolic alkalosis. Unlike rapid respiratory changes, renal adjustment takes hours to days. Interpretation follows a structured sequence. Step 1. Look at pH, acidotic, alkalotic, or normal. Step 2. Look at PiCO2. Does it move in a direction that explains the pH? If yes, the primary problem is respiratory. Step 3. Look at HCO3 pH. If it explains the pH shift, the primary problem is metabolic. Step 4. Ask whether compensation is appropriate. The body always attempts to correct, but never overcorrect. A mismatch suggests a mixed disorder. Example 1, pH 7.25 low, PiCO2 60 high, HCO3 min 24 normal, acidotic, with high CO2, no metabolic compensation. This is acute respiratory acidosis, perhaps due to airway obstruction. Example 2, pH 7.50 high, PiCO2 30 low, HCO3 doubled 24 normal, alkalotic, with low CO2, respiratory alkalosis, possibly from hyperventilation and anxiety or sepsis. Example 3, pH 7.3 low, PiCO2 30 low, HCO3 7.10 low, acidotic, with low bicarbonate, plus low CO2 as partial compensation. Metabolic acidosis causes including diabetic ketoacidosis or renal failure. An additional measure is PiO2, arterial oxygen tension. It indicates how well oxygen transfers from alveoli to blood. Low PiO2 suggests impaired gas exchange, as in pneumonia or pulmonary embolism. Oxygen saturation measured here can confirm pulse oximetry findings. Base excess is sometimes reported, reflecting the metabolic component independent of CO2. A negative value suggests deficit of base metabolic acidosis. A positive value suggests excess metabolic alkalosis. This helps quantify the severity. A vignette illustrates how an ABG saves time. A patient with rapid breathing and confusion is tested. pH 7.110, PiCO 218, HCO3 Nemer 6 points. Severe metabolic acidosis with partial respiratory compensation. With history of diabetes, this points toward diabetic ketoacidosis. The red flag is severe acidosis with altered mental status, an emergency needing immediate care. Physiologically, the body uses 3 layers of defense. Buffers in blood act within seconds, the lungs adjust ventilation within minutes, and kidneys adjust bicarbonate over days. Each defense has limits, which is why ABG patterns carry urgency. Even the most complex tables reduce to a few questions. Is pH high or low? Is the change respiratory or metabolic? Is the compensation appropriate? With patient practice, patterns replace confusion. Numbers on a printout can appear abstract. To see structure more directly, clinicians often turn to imaging. The chest X-ray is the simplest window, and it reveals much when read systematically. A flat film, shades of black and white, can feel like a puzzle at first glance. Yet the chest X-ray, one of the oldest imaging tools, remains central in clinical reasoning. Its value lies not in artistic interpretation, but in a systematic approach that reduces error and reveals patterns hidden in plain sight. The ABC method offers structure. A for airway is the trachea midline or pushed aside by mass or collapse. Are the main bronchi clear? B for bones, ribs, clavicle, spine fractures, lesions, or alignment issues may appear. C for cardiac silhouette is the heart size within normal limits or enlarged relative to the thoracic cavity. Borders should be sharp, not blurred. D for diaphragm, dome should be smooth, free air beneath suggests perforation, costophrenic angles should be sharp, not blunted by fluid. E for everything else, lungs themselves, soft tissues, devices such as lines or tubes. Lung fields hold particular clues. Increased whiteness may reflect consolidation from pneumonia, fluid from edema, or collapse of tissue. Increased darkness may suggest hyperinflation as in chronic obstructive pulmonary disease or air outside the lung in pneumothorax. Comparing both sides is critical. Symmetry often tells the story. Common pitfalls include focusing on the obvious and missing subtle danger. A pneumonia in one lobe may draw the eye, while a small pneumothorax hides at the edge. Foreign objects like a misplaced nasogastric tube can be overlooked unless specifically checked. Systematic reading, always airway, bones, cardiac, diaphragm, everything, prevents such omissions. Technique matters too. A film taken during full inspiration reveals more lung. Poor inspiration can mimic pathology. Rotation alters the apparent size of the heart. Over or under exposure can hide lesions. The clinician must assess quality before interpretation. A vignette illustrates the method. A patient with fever and cough has an X-ray showing a wedge-shaped area of whiteness in the right lower lung zone, obscuring the diaphragm border. This pattern suggests lobar pneumonia. The red flag is any patient with respiratory distress and such consolidation, particularly if oxygen saturation is low, requiring timely care. Mechanistically, X-rays are beams of ionizing radiation that pass through tissues. Dense structures like bone absorb more and appear white, air absorbs little and appears black, soft tissues fall in between. Contrast arises from these differences, allowing recognition of patterns. Order brings calm. When faced with complexity, moving step by step airway, bones, cardiac, diaphragm, everything transforms overwhelm into manageable sequence. Yet the chest X-ray is just one window. Other imaging modalities, ultrasound, computed tomography, magnetic resonance offer different strengths and limitations. Knowing when and why to use them is the next part of the story. The body can be imaged in many ways, each tool with strengths and limitations. Ultrasound, computed tomography, and magnetic resonance imaging form the next tier after plain radiographs, offering resolution, depth, and contrast that expand the clinician's vision. Choosing among them requires balancing accuracy, safety, speed, and availability. Ultrasound uses high-frequency sound waves emitted from a handheld probe. Echoes reflect back from tissues of different densities, producing real-time images. Its strengths are immediacy, portability, and absence of radiation. It excels at visualizing fluid, whether in the abdomen, chest, or heart. Bedside ultrasound can detect gallstones, confirm pregnancy, estimate cardiac function, or guide procedures like fluid drainage. Its limitations are operator dependence and difficulty imaging through bone or air, which scatter sound. Computed tomography, or CT, uses rotating X-ray beams and computer reconstruction to create cross-sectional slices. It offers far greater detail than plain films, especially for lungs, bones, and complex anatomy. CT angiography visualizes blood vessels after contrast injection, identifying clots or aneurysms. Its limitations are radiation exposure and the need for intravenous contrast, which can stress kidneys or trigger allergic reactions. Despite this, CT is often the fastest route to diagnosis in emergencies such as trauma or stroke. Magnetic resonance imaging, or MRI, uses powerful magnets and radio waves to align hydrogen atoms and measure their signals. The result is exquisite soft tissue contrast without ionizing radiation. MRI excels in brain, spinal cord, joints, and soft tissue tumors. Limitations include cost, time, and contraindications such as certain metal implants or severe claustrophobia. Motion blurs images, so patients must remain still, and acutely unstable patients often cannot tolerate the environment. Each modality carries safety considerations. Ultrasound is generally safe. CT requires awareness of radiation dose, especially in children or repeated studies. MRI requires strict screening for metallic objects and monitoring for heating or device interference. In pregnant patients, ultrasound and MRI are usually preferred over CT when possible. A clinical sketch illustrates the decision process. A middle-aged patient presents with sudden severe headache. Ultrasound is not helpful here. CT without contrast is fast and sensitive for acute bleeding, the first choice. If CT is negative but suspicion remains, MRI provides higher sensitivity for subtle strokes. The red flag here is thunderclap headache with neurological deficit. Immediate imaging is essential. Mechanistically, each modality sees the body differently. Sound reflection, X-ray absorption, or magnetic resonance of hydrogen nuclei. The clinician chooses the lens most suited to the question, always balancing benefit and risk. Tools differ, but the principle endures. Ask the right question before choosing the instrument. Clarity comes not from using every tool, but from selecting the one that fits. With imaging in mind, the story turns inward again to physiology. How does the heart actually move blood, and what forces shape its rhythm? The cardiovascular system offers the next essential lesson. Picture the heart as a muscular pump, no larger than a clenched fist, resting in the center of your chest between the lungs. It beats day and night without pause, circulating blood through vessels that stretch thousands of kilometers. Each beat reflects not only the biology of muscle and electricity, but also the physics of pressure, flow, and resistance. Understanding its function begins with three interrelated concepts: preload, afterload, and cardiac output. Together they form a map of cardiovascular physiology, explaining both normal function and disease. Preload refers to the stretch of the ventricles at the end of filling, just before contraction. It is determined largely by venous return, the volume of blood returning to the heart. As blood fills the ventricle, muscle fibers elongate. According to the Frank-Starling principle, a moderate stretch enhances the force of contraction, much like stretching a spring increases its recoil. However, too much stretch overwhelms efficiency, and contraction becomes weaker. Preload therefore represents both opportunity and risk. Adequate filling supports strong ejection, but excessive filling contributes to congestion and failure. Afterload is the pressure the ventricle must overcome to eject blood into circulation. For the left ventricle, afterload is defined by systemic vascular resistance, the collective resistance of arteries throughout the body. For the right ventricle, it is pulmonary vascular resistance, the pressure within the lungs. High afterload increases workload. A narrowed aorta or stiff systemic arteries force the heart to pump harder, thickening the muscle over time but eventually leading to exhaustion. Conversely, low resistance makes ejection easier but can reduce perfusion pressure if too low. Cardiac output is the volume of blood pumped per minute. It equals stroke volume multiplied by heart rate. Stroke volume itself depends on preload, afterload, and contractility, the intrinsic strength of the heart muscle independent of loading conditions. When demand rises, such as during exercise, sympathetic stimulation increases heart rate and enhances contractility, elevating output. When the heart fails, output falls. Organs sense reduced delivery of oxygen and nutrients, and compensatory mechanisms activate to restore balance. Each contraction resonates with audible markers. The first heart sound, often described as lub, corresponds to closure of the mitral and tricuspid valves at the onset of systole. The second heart sound, dub, marks closure of the aortic and pulmonary valves at the end of systole. Abnormal sounds or murmurs arise when valves fail to open or close properly. Stenosis narrows an orifice, forcing blood through a restricted space and producing turbulent vibrations. Regurgitation allows backflow, creating murmurs as blood moves in the wrong direction. Though auscultation requires skill, the underlying principle is simple. Disrupted flow generates audible vibrations, and these vibrations reveal structural problems within the valves. The vascular system partners in this dance of pressure and flow. Arteries carry blood outward under pulsatile pressure, their elastic walls stretching with systole and recoiling with diastole. Veins, thinner and more compliant, return blood to the heart, aided by valves and by muscle contractions that compress vessels during movement. Capillaries with thin walls allow exchange of gases, nutrients, and waste between blood and tissues. Blood pressure, the measurable force within arteries, reflects both cardiac output and systemic vascular resistance. When resistance rises, as in arterial stiffness or vasoconstriction, afterload rises and blood pressure increases. When blood volume falls from dehydration or hemorrhage, preload decreases, reducing cardiac output and pressure. The circulatory system therefore depends on a delicate equilibrium. A clinical vignette illustrates integration of these ideas. A patient presents with shortness of breath when climbing stairs. On examination, the physician hears a systolic murmur at the cardiac apex, radiating toward the axilla. This pattern suggests mitral regurgitation, where blood leaks backward from ventricle to atrium during systole. The regurgitation reduces forward stroke volume, so output falls. To compensate, the ventricle dilates, increasing preload, but over time the volume load overwhelms efficiency. The red flag here is exertional breathlessness coupled with a murmur, findings that may indicate significant valve disease requiring further evaluation and treatment. Mechanistically, the heart's reliability depends on electrical conduction. The sinoatrial node, located in the right atrium, generates impulses that spread across the atria, producing contraction. The signal pauses at the atrioventricular node, allowing ventricular filling before passing into the bundle of His, bundle branches and Purkinje fibers, which distribute the impulse rapidly through ventricular muscle. This conduction system ensures that atria and ventricles contract in a coordinated fashion. Disturbances of conduction, known as arrhythmias, disrupt synchrony. Some arrhythmias merely cause palpitations, others reduce cardiac output dramatically, producing dizziness, syncope, or cardiac arrest. Consider another vignette. A patient reports palpitations and sudden lightheadedness. Electrocardiography shows atrial fibrillation, a rhythm where chaotic atrial impulses bombard the atrioventricular node. The ventricles contract irregularly, reducing filling and output. The red flag is palpitations with syncope or chest pain, which may signal dangerous arrhythmia requiring immediate care. The heart's physiology extends beyond mechanics to adaptation. In response to chronic high afterload, such as long-standing hypertension, the left ventricle thickens, a process known as hypertrophy. Initially, this strengthens contraction, but the thickened muscle becomes stiff, impairing filling and raising filling pressures. Similarly, chronic volume overload from regurgitant valves dilates chambers, stretching fibers to maintain stroke volume, but eventually leading to systolic failure. These adaptations reflect the heart's resilience and also its vulnerability. Compensatory mechanisms succeed in the short term but carry long-term costs. Cardiac output is not uniform across tissues, but distributed according to demand. During exercise, blood flow increases to muscles, skin, and heart, while it decreases to digestive organs. This redistribution is mediated by autonomic nerves and local metabolites that dilate arterioles where activity is high. Even at rest, autoregulation ensures that vital organs like brain and kidney receive relatively constant perfusion across a wide range of pressures. This capacity to redirect flow sustains life under diverse circumstances, from running in heat to standing after rest. Heart sounds and murmurs further illustrate integration of structure and function. Aortic stenosis, for example, produces a crescendo-decrescendo systolic murmur, heard best at the right upper sternal border. The narrowed aortic valve increases afterload, raising pressure within the left ventricle. Patients may present with chest pain, syncope, and breathlessness, the classic triad of severe disease. The red flag is exertional fainting, a sign of critically reduced output. In contrast, tricuspid regurgitation produces a systolic murmur increasing with inspiration, reflecting backward flow into the right atrium. These nuances allow clinicians to map turbulence to anatomy. The circulation of blood also involves the coronary arteries, which supply the heart itself. These vessels fill mainly during diastole, when relaxation relieves compression of intramural vessels. Narrowing from atherosclerosis reduces supply. When demand exceeds delivery, ischemia develops, producing chest pain known as angina. If obstruction is sudden and complete, infarction occurs, killing heart muscle. The red flag is chest pain at rest, radiating to arm or jaw, requiring immediate attention. Coronary circulation demonstrates the paradox of the heart. The organ that supplies all others depends on fragile vessels of its own. The physics of circulation add another layer. Blood flow depends on pressure gradients and resistance. Resistance, according to Poiseuille's law, increases with vessel length and viscosity, but especially with smaller radius. A modest reduction in arterial diameter dramatically raises resistance, explaining why vasoconstriction elevates pressure and why atherosclerotic narrowing impairs flow. The pulse you feel in your wrist is the pressure wave transmitted through arteries as blood is ejected from the heart. Its shape and strength reflect arterial stiffness and stroke volume. Blood pressure regulation integrates neural and hormonal systems. Baroreceptors in carotid arteries and aortic arch sense stretch and adjust autonomic tone. When pressure falls, sympathetic activity rises, increasing heart rate, contractility, and vascular tone. When pressure rises, parasympathetic input slows the heart and reduces tone. The kidneys contribute through the renin-angiotensin-aldosterone system, conserving sodium and water when volume is low. Together, these mechanisms maintain perfusion across challenges. A patient vignette illustrates systemic interaction. An individual collapses after standing suddenly, blood pressure falls, pulse quickens, and perfusion drops. This orthostatic hypotension reflects inadequate autonomic adjustment or low blood volume. The red flag is fainting with injury or recurrent collapse, which may signify underlying cardiovascular compromise. At the microscopic level, the capillary bed is the site of exchange. Hydrostatic pressure drives fluid outward, while oncotic pressure from plasma proteins draws fluid inward. A balance between these forces determines filtration and absorption. Disruption of this balance produces edema. For example, reduced albumin in liver disease lowers oncotic pressure, causing fluid to accumulate in tissues. Increased venous pressure in heart failure raises hydrostatic pressure, producing swollen legs and lungs filled with fluid. The kidney and lymphatic systems assist in controlling this balance, but the heart's role remains central. The heart's resilience lies in rhythm. With each cycle, it contracts and relaxes, maintaining flow across decades of life. Even under strain, it adjusts with remarkable flexibility, increasing rate, contractility, or chamber size to meet demands. Observing its logic, preload, afterload, output, invites appreciation of pressure and flow, not as enemies but as partners in balance. When balance fails, the signs appear as murmurs, swelling, chest pain, or fainting, each a signal from the pump that sustains existence. The heart embodies endurance through rhythm. It works with physics as much as with biology, obeying principles of stretch, resistance, and flow. To listen to its sounds and observe its adaptations is to witness balance, maintained by continual motion. From circulation of blood, attention shifts to the circulation of air. The respiratory system ensures oxygen supply and carbon dioxide removal, a process no less elegant, and its physiology forms the next chapter. Imagine breathing in a cool night breeze. The act feels effortless, a rhythm that continues whether you are awake or asleep. Yet beneath this apparent simplicity lies an intricate system of pressures, volumes, and chemical gradients working together to sustain life. The respiratory system draws oxygen into the body, exchanges it for carbon dioxide at the alveoli, and delivers each gas to its proper destination. Without oxygen, cellular metabolism halts within minutes. Without carbon dioxide removal, acidity rises and disrupts every function. To understand this system is to uncover how breath transforms into fuel for cells, and how disruptions at any point reveal themselves in measurable ways. The foundation of respiratory physiology lies in lung volumes. With each gentle breath, you move a tidal volume, the ordinary amount of air exchanged at rest. When you choose to take a deep breath, you call upon inspiratory reserve volume, the extra capacity available above the tidal level. Similarly, when you forcefully exhale beyond a normal breath out, you tap into expiratory reserve volume. Even after the fullest exhalation, a residual volume of air remains within the lungs, preventing collapse and maintaining alveolar patency. Adding these components gives total lung capacity. Clinicians often focus on vital capacity, the maximal air exhaled after maximal inhalation. Vital capacity reflects not only lung structure, but also muscle strength and chest wall mechanics, making it a valuable indicator of function. Beyond static volumes, dynamic flow matters. Minute ventilation is the total volume of air moved per minute, calculated as tidal volume multiplied by respiratory rate. Alveolar ventilation refines this by subtracting dead space, the portion of airways where no gas exchange occurs, such as the trachea and bronchi. Effective respiration depends more on alveolar ventilation than on sheer volume. Breathing rapidly but shallowly may move plenty of air overall, yet deliver little oxygen to alveoli, leaving gas exchange inadequate. Gas exchange itself occurs by diffusion across the thin alveolar capillary membrane. Partial pressure gradients drive this process. In alveolar air, oxygen pressure is higher than in venous blood, so oxygen diffuses inward. Carbon dioxide, at higher partial pressure in venous blood than alveolar air, diffuses outward. This simultaneous exchange keeps oxygen supply and carbon dioxide clearance aligned with cellular metabolism. Hemoglobin within red blood cells plays a central role. Its capacity to bind oxygen follows cooperative kinetics. Binding of one oxygen molecule increases affinity for the next. This creates the sigmoidal shape of the hemoglobin-oxygen dissociation curve. In the lungs, where oxygen pressure is high, hemoglobin becomes nearly saturated. In tissues where oxygen pressure is lower, hemoglobin releases oxygen efficiently. Shifts in this curve occur with pH, temperature, and carbon dioxide levels, known as the Bohr effect. For example, exercising muscles produce heat and acid, shifting the curve to favor oxygen release precisely where it is needed most. The system's efficiency depends not only on ventilation, but also on perfusion. Ventilation describes the movement of air in and out of alveoli. Perfusion describes the flow of blood through pulmonary capillaries. The ratio of ventilation to perfusion, often abbreviated VQ, determines gas exchange efficiency. When ventilation is adequate but perfusion absent, as in pulmonary embolism, alveoli are ventilated but blood cannot pick up oxygen. When perfusion is present but alveoli are fluid-filled or collapsed, as in pneumonia or atelectasis, blood passes through without being oxygenated. Even small mismatches in this balance reduce overall oxygen levels. The lung compensates with mechanisms such as hypoxic vasoconstriction, diverting blood away from poorly ventilated regions, but compensation has limits. At the bedside, clinicians use tools that translate these physiological processes into monitoring signals. Pulse oximetry, widely familiar, estimates oxygen saturation by measuring light absorption through a fingertip or earlobe. It is quick, non-invasive, and continuous, but not infallible. It cannot distinguish oxygen from carbon monoxide bound to hemoglobin, so saturation may appear normal in carbon monoxide poisoning. It also lags behind rapid changes in ventilation and provides no direct measure of carbon dioxide clearance. Capnography addresses this gap. By analyzing exhaled gas, it measures end-tidal carbon dioxide and provides a waveform that reflects both ventilation and circulation. In anesthesia and critical care, capnography serves as an early warning system for airway obstruction, hypoventilation, or equipment disconnection. A clinical vignette illustrates these principles. A patient under sedation is monitored with pulse oximetry, which continues to show normal oxygen saturation. Meanwhile, capnography reveals rising carbon dioxide and a flattening waveform. The patient's airway has become obstructed, preventing exhalation of carbon dioxide even while oxygen remains in the lungs temporarily. Here, capnography detects the crisis earlier than oximetry. The red flag is any sudden loss of waveform or abrupt rise in end-tidal carbon dioxide, signaling airway compromise that requires immediate professional attention. Mechanistically, breathing is driven by neural centers in the brainstem. The medulla generates rhythmic impulses to the diaphragm and intercostal muscles. The pons fine-tunes timing. Chemoreceptors in the medulla and carotid bodies sense carbon dioxide, oxygen, and pH, adjusting respiratory drive. High carbon dioxide or low pH stimulates stronger breathing, while very low oxygen adds additional drive. At rest, exhalation is passive, relying on elastic recoil of lungs and chest wall. During exertion, abdominal and intercostal muscles actively force air out. Compliance, the ease with which lungs and chest expand, determines the work of breathing. Stiff lungs and fibrosis reduce compliance, requiring effort to inhale, while overly compliant lungs and emphysema fail to recoil, trapping air inside. The respiratory system also interacts with circulation in profound ways. The right ventricle pumps blood into pulmonary arteries, distributing it across alveoli. Changes in lung volume during breathing affect venous return and cardiac output, coupling respiration to hemodynamics. Conditions such as pulmonary hypertension, in which resistance within lung vessels rises, strain the right heart and impair oxygen delivery. Diseases highlight the delicacy of this system. In asthma, inflammation narrows airways, impairing ventilation while perfusion persists, creating mismatch. In chronic obstructive pulmonary disease, destruction of alveolar walls reduces surface area for exchange. In pulmonary fibrosis, thickened membranes slow diffusion. Each condition reveals how disruption at one level, airway, alveolus, membrane, reverberates through the entire system. Another vignette deepens the picture. A patient with sudden chest pain and shortness of breath is found to have a pulmonary embolism. Blood clot blocks flow to a region of lung. Ventilation there continues, but perfusion ceases, creating dead space. Pulse oximetry shows falling oxygen saturation, while arterial blood gases confirm impaired exchange. The red flag here is acute shortness of breath with chest pain and low oxygen in someone at risk for clots, requiring immediate evaluation. Technological measurement extends to blood gases, offering detailed analysis of oxygen, carbon dioxide, and acid-base status. Arterial blood gas sampling, though invasive, reveals partial pressures directly, unlike pulse oximetry. Interpretation requires considering ventilation, diffusion, and perfusion together. For instance, a high carbon dioxide level suggests inadequate ventilation, while a low oxygen level despite normal ventilation suggests mismatch or diffusion limitation. Breathing is thus not only a matter of airflow, but a balance of volumes, pressures, diffusion, and blood flow. Air and blood must meet in proper ratio. Hemoglobin must load and unload oxygen in response to local needs. Neural control must adjust rhythm to metabolic demand. Failures at any link manifest as measurable changes, saturation, carbon dioxide levels, acid-base shifts, allowing clinicians to trace symptoms back to mechanisms. Reflection. Breathing illustrates the elegance of balance. Each inhalation and exhalation is not perfection, but fine-tuned correction. Air and blood meet. Oxygen and carbon dioxide exchange. Pressures rise and fall. Rhythms adjust. To notice this is to see how stability arises from continual adaptation. From the study of gas exchange, attention now shifts to the regulation of fluid and electrolytes. The kidneys, with their intricate structures and hormonal loops, ensure that water, salt, and blood pressure remain in equilibrium. That landscape unfolds in the next chapter. Water trickles through a winding filter drop by drop until what remains is precisely balanced. This quiet, constant process is the kidney's work. Two fist-sized organs tucked beneath the ribcage maintain stability in the body by filtering blood, reclaiming what is needed, and excreting what is not. Each kidney contains about 1 million nephrons, the microscopic units of function that serve as the true regulators of internal fluid and chemical composition. Their activity is central to controlling not only water and electrolytes, but also blood pressure, acid-base balance, and even the activation of hormones essential for bone health and red blood cell production. At the entry point of each nephron lies the glomerulus, a tuft of capillaries ensheathed by Bowman's capsule. Blood pressure within these capillaries forces plasma water and dissolved solutes across a specialized barrier of endothelial cells, basement membrane, and podocytes. Large proteins and cells are retained, while water, salts, glucose, amino acids, and small metabolites enter the filtrate. This initial step is non-selective, producing a filtrate whose composition resembles plasma minus large proteins. What follows in the tubular system is a series of refinements where reabsorption and secretion transform the crude filtrate into precisely balanced urine. The proximal tubule reabsorbs the majority of filtered load. Roughly 2/3 of sodium chloride in water are reclaimed here, along with essentially all filtered glucose and amino acids. Specialized transporters coordinate this work. Sodium-glucose cotransporters recover sugar while aquaporins facilitate water movement. This section also secretes organic acids and bases, including certain drugs, into the filtrate. Failure of proximal reabsorption, as in some inherited disorders, produces massive losses of essential solutes. The loop of Henle plunges into the renal medulla, creating the conditions necessary for urine concentration. Its descending limb is permeable to water but not solutes, allowing water to exit into the concentrated medullary interstitium. Its ascending limb is impermeable to water but actively transports sodium and chloride outward, further increasing the osmotic gradient. This countercurrent multiplier mechanism establishes a steep gradient of solute concentration from cortex to medulla. The collecting ducts passing through this gradient can then adjust water reabsorption to produce dilute or concentrated urine as needed. The distal convoluted tubule fine-tunes electrolytes. Sodium and chloride continue to be reabsorbed, while calcium reabsorption here is under hormonal regulation by parathyroid hormone. Potassium and hydrogen ions may be secreted into filtrate, depending on the body's needs. The collecting duct represents the final decision point. Here, hormonal signals exert their greatest influence. One such system is the renin-angiotensin-aldosterone axis. When the kidney senses reduced perfusion pressure or sodium delivery, juxtaglomerular cells release renin. Renin cleaves angiotensinogen, a circulating protein from the liver, into angiotensin I. This is converted by angiotensin-converting enzyme into angiotensin II, a potent effector. Angiotensin II constricts blood vessels, raising systemic pressure. It stimulates the adrenal cortex to release aldosterone, which acts on distal nephron segments to increase sodium and water reabsorption, conserving volume. It also enhances thirst and antidiuretic hormone release, coordinating cardiovascular, renal, and behavioral responses. Antidiuretic hormone, secreted by the posterior pituitary, adjusts water handling in the collecting ducts. In its presence, aquaporins are inserted into the tubular membrane, allowing water to flow back into blood down the osmotic gradient. When ADH levels are low, aquaporins are removed, leaving ducts impermeable, and dilute urine flows outward. This mechanism explains the body's flexibility: concentrated urine during dehydration, copious dilute urine during excess water intake. Electrolyte regulation is inseparable from these systems. Sodium, the main extracellular cation, dictates water distribution and volume. Potassium, vital for nerve impulses and muscle contraction, is tightly controlled by renal secretion in the distal nephron. Hyperkalemia, or excess potassium, threatens the heart with dangerous arrhythmias, while hypokalemia impairs muscle and nerve function. Calcium and phosphate balance also hinge on renal handling. The kidney activates vitamin D to calcitriol, which promotes intestinal calcium absorption. Parathyroid hormone increases calcium reabsorption and phosphate excretion. Together, these processes secure bone integrity and cellular signaling. Acid-base balance is another critical task. The kidney secretes hydrogen ions and generates bicarbonate, buffering plasma pH. In acidosis, hydrogen secretion rises and new bicarbonate enters circulation. In alkalosis, bicarbonate reabsorption diminishes. These adjustments are slower than respiratory compensation but provide lasting correction. Without renal buffering, minor metabolic disturbances would accumulate into life-threatening derangements. Clinical observations reveal these mechanisms in action. A dehydrated patient presents with low blood pressure, dry mucous membranes, and scant concentrated urine. Laboratory tests show elevated blood urea, nitrogen, and creatinine, markers of reduced filtration. Here the kidney has conserved water maximally, but systemic losses have outpaced its ability to compensate. Another patient presents with confusion and drowsiness. Labs reveal hyponatremia, dangerously low sodium. History uncovers excessive water intake without solute replacement, overwhelming the kidney's capacity to excrete free water. In both cases, understanding renal physiology clarifies the imbalance. A red flag example underscores urgency. An older adult develops swelling in the legs, reduced urine output, and rising creatinine levels. This constellation suggests acute kidney injury, a state where filtration plummets. Causes may include reduced perfusion from heart failure, intrinsic damage from toxins or inflammation, or obstruction of urinary outflow. Whatever the trigger, the rapid decline threatens accumulation of potassium, acids, and fluid. Professional evaluation is crucial whenever declining urine output couples with fluid overload or altered mental status. Mechanistically, each nephron acts as a decision maker. Tens of thousands of transporters shuttle ions, many powered by sodium-potassium ATPase pumps that consume significant energy. The collective output of 1 million nephrons per kidney maintains plasma composition within narrow ranges despite wide fluctuations in intake. Drinking liters of water or ingesting salty meals produces only minor changes in blood chemistry because nephrons adjust filtration, reabsorption, and secretion dynamically. Another vignette illustrates integration. A patient treated for high blood pressure with diuretics develops muscle cramps and irregular heartbeat. Lab tests reveal hypokalemia. The diuretic increased sodium delivery to distal nephron segments, where sodium reabsorption is coupled with potassium secretion. Excessive potassium loss resulted. The red flag here is muscle weakness or arrhythmia in a patient on diuretics, signaling the need for urgent monitoring. Renal physiology also connects to systemic regulation of blood pressure. Beyond urease and ADH, the kidney produces erythropoietin, stimulating red blood cell production in bone marrow, linking oxygen delivery with renal sensing of hypoxia. It also contributes to prostaglandin synthesis, influencing vascular tone. These endocrine roles demonstrate the kidney's scope beyond excretion. Pathology demonstrates the kidney's vulnerability. In chronic kidney disease, gradual loss of nephrons reduces filtering capacity. Waste products accumulate. Anemia develops from reduced erythropoietin, and bone health declines from impaired vitamin D activation. Hypertension both causes and results from kidney injury, creating a vicious cycle. Recognition and early intervention slow progression but cannot restore lost nephrons. Dialysis or transplantation becomes necessary when filtration falls below a critical threshold. Mechanistically, the nephron's design reveals evolutionary precision. Filtration ensures broad clearance of plasma contents. Reabsorption selectively retrieves valuable solutes. Secretion adds waste and excess ions. Together, these steps maintain homeostasis with remarkable efficiency. The kidneys do not seek abundance or emptiness, only balance. Their calibration embodies resilience, constant correction amid shifting intake, losses, and demands. The kidneys exemplify precision in adaptation. By balancing inputs and outputs, they preserve stability without stasis. Their function is not abundance, but harmony, where every drop filtered and every ion reabsorbed contributes to equilibrium. To appreciate their work is to see how stability can arise from quiet persistence. Having examined fluid balance, attention now turns to the nervous system's handling of pain. Signals within nerves shape perception as much as they reflect damage, and understanding them changes how discomfort is interpreted. The body's wiring hums beneath the surface, carrying signals and pulses of electricity, and waves of neurotransmitter release. This vast network, the nervous system, governs every conscious thought, voluntary motion, and hidden reflex. It not only allows you to move a hand, recall a memory, or feel a sensation, but also keeps organs in rhythm and interprets the warning cry of pain. At its core, the nervous system divides into voluntary and autonomic domains. The autonomic portion, largely unconscious, provides continuous adjustments that sustain balance. Within it lie two complementary divisions, the sympathetic and parasympathetic systems. Their interplay illustrates the precision with which the body maintains homeostasis. The sympathetic system prepares the organism for challenge. Its fibers emerge from thoracic and lumbar segments of the spinal cord and travel through ganglia before reaching organs. Neurotransmitters such as norepinephrine are released at target sites, binding to adrenergic receptors on heart vessels and glands. The results are coordinated and rapid. Heart rate accelerates, cardiac contractility strengthens, pupils dilate, airways widen, sweat glands activate, and blood shifts away from intestines toward skeletal muscles. Glucose is mobilized from liver stores. Collectively, these changes support the fight or flight state, priming the body for exertion or defense. The parasympathetic system provides the counterpoint. Its fibers arise from brainstem nuclei and the sacral spinal cord, traveling through long preganglionic pathways to reach ganglia near target organs. Acetylcholine is the main neurotransmitter here, binding muscarinic receptors. The effects are restorative. Heart rate slows, intestinal motility and secretions increase, pupils constrict, and energy stores replenish. This is the rest and digest state, encouraging repair, growth, and recovery. Neither branch is inherently superior. Health depends on balance. Excess sympathetic tone over time contributes to hypertension, anxiety, and metabolic strain. Excess parasympathetic activity can slow the heart excessively or impair circulation. Overlaying this regulatory system is the phenomenon of pain perception. Pain begins at nociceptors, specialized nerve endings distributed in skin, muscles, joints, and viscera. These receptors detect mechanical stretch, extreme temperatures, or chemical mediators released by damaged tissues. When triggered, they generate electrical impulses that travel along peripheral nerves toward the spinal cord. In the dorsal horn of the cord, signals synapse onto second-order neurons. These cross to the opposite side and ascend in the spinothalamic tract toward the brain. Along the way, modulation occurs. Local inhibitory interneurons release gamma-aminobutyric acid or glycine to reduce transmission. Descending fibers from the brainstem release serotonin, norepinephrine, and endogenous opioids like endorphins, dampening perception when survival demands focus elsewhere. Pain classification provides clarity. Nociceptive pain arises from direct tissue injury, such as a cut, burn, or sprain. It tends to be sharp or aching and correlates with inflammation or trauma. Neuropathic pain originates from nerve damage or dysfunction, producing burning, tingling, or electric-like sensations, often in a distribution matching nerve pathways. Central pain stems from abnormal processing within spinal cord or brain, sometimes persisting after original injury heals. Differentiating these categories guides therapy. Anti-inflammatories may relieve nociceptive pain, while neuropathic pain often requires agents that modulate nerve excitability. Management of pain follows a proportional approach. The analgesic ladder illustrates this principle. Begin with basic agents, escalate if needed, and integrate non-drug strategies. Simple analgesics, physical therapy, and cognitive methods may suffice for mild pain. For persistent or severe pain, stronger medications or interventional procedures may be appropriate. The goal is adequate relief while minimizing side effects and avoiding overtreatment. A clinical vignette demonstrates application. A patient reports burning pain in both feet, worse at night. On examination, sensation is reduced in a stocking distribution, extending from toes upward. History reveals long-standing diabetes. This pattern fits diabetic neuropathy, a neuropathic pain condition caused by chronic metabolic injury to peripheral nerves. The red flag is pain accompanied by progressive sensory loss or weakness, which may indicate worsening nerve damage requiring professional evaluation. Mechanistically, the nervous system's duality is striking. It generates pain signals to warn of harm, yet can also suppress them when survival requires attention elsewhere. Soldiers in battle sometimes feel no pain from severe wounds until danger has passed, evidence of powerful descending inhibition at work. Pain, therefore, is not a simple input, but a perception shaped by context, emotion, and brain modulation. Another example reinforces this complexity. A patient experiences chronic back pain long after tissue healing has occurred. Imaging shows no structural abnormality, yet central sensitization within the spinal cord has amplified ordinary signals into persistent pain. The red flag in such cases is unrelenting pain with functional decline. Pain is both a signal and a story. It can represent ongoing tissue injury or the nervous system's memory of past harm. Listening to pain with curiosity rather than fear helps distinguish warning from echo. That distinction changes how calmly one responds and how treatment is approached. The nervous system as a whole illustrates dynamic control through rapid signals. In milliseconds, it adjusts heart rate, blood pressure, posture, and perception. It ensures coordination between body and environment, activating defense when needed, soothing into restoration when safe, and communicating distress through pain when damage occurs. From this electrically tuned orchestra of nerves, attention now shifts to another mode of communication. Unlike the swift sparks of neurons, the endocrine system works through chemical messages carried in blood, orchestrating growth, metabolism, reproduction, and cycles of time with slower but equally essential rhythms. Imagine a network of messengers traveling not by wires but by blood, carrying information silently yet decisively from one organ to another. This is the endocrine system, where hormones, chemical signals secreted into circulation, coordinate metabolism, growth, reproduction, and stress responses. Unlike electrical impulses of nerves which act quickly and locally, hormones act more slowly but over broader distances, linking brain, glands, and target tissues into a complex web of feedback loops. The strength of this system lies in its ability to regulate processes that unfold not in seconds but across hours, days, or even years, weaving time into physiology. One central pathway is the hypothalamic-pituitary-thyroid axis. In the hypothalamus, neurons release thyrotropin-releasing hormone into a portal circulation that feeds directly into the anterior pituitary. The pituitary responds by secreting thyroid-stimulating hormone, which then reaches the thyroid gland in the neck. The thyroid produces thyroxine and triiodothyronine, hormones that accelerate metabolism in nearly every tissue. Their effects range from increasing heat production to enhancing heart rate and stimulating oxygen consumption in cells. Rising levels of T4 and T3 feed back to the hypothalamus and pituitary, reducing further secretion and maintaining balance. When this loop is disrupted, symptoms emerge. In hypothyroidism, metabolism slows, producing fatigue, weight gain, cold intolerance, and slowed reflexes. In hyperthyroidism, metabolism accelerates, producing palpitations, weight loss, anxiety, and heat intolerance. Both conditions illustrate the delicacy of endocrine equilibrium. Another axis is the hypothalamic-pituitary gonadal system, responsible for reproduction. The hypothalamus releases gonadotropin-releasing hormone in rhythmic pulses. The pituitary responds by releasing luteinizing hormone and follicle-stimulating hormone, which act on the ovaries in women and testes in men. In ovaries, they regulate follicle development, ovulation, and production of estrogen and progesterone. In testes, they stimulate testosterone production and spermatogenesis. These sex hormones feed back to regulate hypothalamic and pituitary secretion, shaping menstrual cycles, fertility, and secondary sexual characteristics such as body hair and voice depth. Disturbances in this axis manifest as infertility, irregular menstruation, delayed puberty, or hypogonadism. The hypothalamic-pituitary-adrenal axis governs stress response. Stressful stimuli trigger the hypothalamus to release corticotropin-releasing hormone. The pituitary responds by releasing adrenocorticotropic hormone, which stimulates the adrenal cortex to secrete cortisol. Cortisol mobilizes glucose from stores, enhances cardiovascular tone, and suppresses inflammation. Its levels follow a circadian rhythm, highest in the early morning, preparing the body for activity, and lowest at night, promoting rest. Short-term cortisol release is adaptive, but chronic activation, as in prolonged psychological stress, disrupts metabolism, weakens immunity, disturbs sleep, and can alter mood regulation. This axis exemplifies how hormones translate external challenges into internal adjustments at the cost of long-term strain if balance is not restored. Other important hormones illustrate the diversity of endocrine signals. From the pancreas, insulin lowers blood glucose by promoting uptake into muscle and fat, and by stimulating storage as glycogen, while glucagon raises glucose by stimulating liver release. The balance between these two hormones stabilizes energy supply. The parathyroid glands secrete parathyroid hormone, which raises blood calcium by stimulating bone resorption and enhancing kidney reabsorption. Vitamin D works alongside, increasing intestinal absorption of calcium. Melatonin, produced by the pineal gland in response to darkness, signals night to the body, regulating sleep-wake cycles and influencing circadian timing. A clinical vignette highlights interplay within this system. A patient reports fatigue, weight gain, and dry skin. Examination reveals slowed reflexes. Laboratory tests show elevated thyroid-stimulating hormone with low thyroxine, consistent with hypothyroidism. The red flag in such a case is severe fatigue accompanied by swelling of the face or extremities and slowing of mental status, which may indicate progression toward myxedema coma, a life-threatening state requiring urgent attention. Here, the disturbance of one gland reverberates across multiple body systems, showing the power of endocrine integration. Mechanistically, hormone signaling depends on receptor binding. Though hormones travel broadly in blood, they act only where receptors exist. Lipid-soluble hormones such as steroids and thyroid hormones cross cell membranes, bind intracellular receptors, and influence gene transcription directly. Water-soluble hormones such as peptides and amines bind to receptors on cell surfaces, triggering second messenger cascades that alter cellular activity. This dual architecture explains both the specificity of endocrine action and its ability to affect many tissues simultaneously. Rhythms are another defining feature of endocrinology. Beyond the circadian rhythm of cortisol, the body maintains ultradian rhythms repeating within hours and infradian rhythms spanning weeks. Pulses of gonadotropin-releasing hormone determine reproductive cycles. Monthly cycles of estrogen and progesterone orchestrate ovulation and menstruation. Growth hormone is secreted in bursts during sleep, aligning growth and repair with rest. These rhythms ensure that hormone action synchronizes with environmental cycles of light, feeding, and activity. When rhythms are disrupted by jet lag, shift work, or chronic sleep deprivation, hormonal patterns fragment, linking circadian misalignment to metabolic disease, reproductive problems, and mood disturbances. Another clinical sketch underlines this. A shift worker develops weight gain, high blood pressure, and poor sleep. Investigation reveals altered cortisol rhythm and impaired glucose tolerance. The red flag is progressive fatigue with metabolic changes in the setting of circadian disruption. This case shows that endocrine health depends not only on glands and receptors, but also on temporal harmony with the environment. The endocrine system also interfaces with immunity and the nervous system. Cortisol suppression of inflammation demonstrates this link. Stress hormones influence immune surveillance, explaining why chronic stress increases vulnerability to infection. Thyroid hormones affect neuronal development, highlighting their importance during fetal life. Sex hormones influence bone density, cardiovascular risk, and mood. Insulin resistance links metabolic and immune pathways, connecting obesity, inflammation, and diabetes. Endocrinology thus stands at crossroads, integrating multiple organ systems into coherent responses. Mechanistically, feedback loops anchor the system. Negative feedback is the rule. Rising hormone levels suppress upstream release, preventing runaway effects. In some cases, positive feedback sharpens transitions. For example, estrogen surges during the menstrual cycle stimulate luteinizing hormone release, triggering ovulation. These loops stabilize the system, balancing responsiveness with control. The endocrine system teaches patience. Its signals travel slowly, its effects accumulate gradually, and its feedback loops stabilize rather than excite. It reminds you that steady rhythms, not sudden surges, sustain balance. Endocrine health lies not in forceful intervention, but in quiet harmony, a lesson as much about life as about physiology. With hormones setting the tempo of the body's symphony, the story now moves to digestion and to the microbial partners that share your gut, adding another layer to the orchestra. Imagine a long folded tube stretching from the mouth to the rectum, lined with secretions, muscles, immune cells, and trillions of microbial inhabitants. This is the gastrointestinal tract, supported by the liver, pancreas, and gallbladder. Its coordinated work is not simply to digest food, but to transform it into usable molecules, absorb them efficiently, defend against pathogens, and host a microbial community whose activity shapes immunity, metabolism, and even mood. The system is both self-contained and deeply integrated into the rest of the body, a living corridor where food becomes fuel and information flows between host and microbes. The process begins in the mouth, where chewing increases surface area and saliva moistens and initiates chemical breakdown. Enzymes in saliva, such as amylase, start digesting starch into smaller sugars, while lingual lipase begins fat digestion. The tongue and teeth also serve mechanical roles, preparing a bolus that is safe to swallow. Swallowing itself is a reflex coordinated by nerves that prevent aspiration into the airway. Already at this stage, digestion is under neural and hormonal regulation, not a passive process. The bolus travels down the esophagus, propelled by peristaltic waves. At the junction with the stomach, the lower esophageal sphincter guards against reflux. When it fails, gastric contents rise, causing heartburn. In the stomach, food is mixed with gastric acid and pepsin. Hydrochloric acid denatures proteins and creates a hostile environment for many microbes. Pepsin, activated in this acidic milieu, begins breaking proteins into peptides. Muscular churning produces a semi-liquid mixture called chyme, which is slowly released into the small intestine. The small intestine is the major site of digestion and absorption. The duodenum receives chyme along with pancreatic juice and bile. Pancreatic enzymes are powerful and varied. Amylase continues carbohydrate digestion, lipase breaks down fats, and proteases such as trypsin and chymotrypsin dismantle proteins into amino acids. Bile produced by the liver and stored in the gallbladder contains bile salts that emulsify fats into micelles, allowing enzymes to act efficiently. The jejunum and ileum provide vast absorptive surface area through villi and microvilli, collectively called the brush border. Here, amino acids and sugars enter capillaries and flow through the portal vein to the liver. Fats absorbed into lymphatic vessels called lacteals travel by a different route before entering circulation. The liver stands as a metabolic hub at this crossroads. It processes absorbed nutrients, converting glucose to glycogen for storage or releasing it back into blood as needed. It synthesizes essential proteins including albumin, which maintains oncotic pressure, and clotting factors which prevent hemorrhage. It detoxifies ammonia into urea for excretion and modifies drugs to make them more excretable. The gallbladder, nestled beneath the liver, stores bile between meals and releases it in response to cholecystokinase when fatty food enters the duodenum. The pancreas has a dual role. Exocrine cells secrete enzymes for digestion, while endocrine islets release insulin and glucagon to regulate glucose balance. The large intestine focuses less on digestion and more on absorption of water and electrolytes. By reclaiming fluid, it compacts waste into stool. Yet its significance extends far beyond plumbing. The colon is home to the microbiota, trillions of bacteria, viruses, and fungi that perform functions the human genome alone could not. They ferment undigested carbohydrates, producing short-chain fatty acids such as acetate, propionate, and butyrate. These molecules nourish colonocytes, influence immune responses, and may even modulate distant organs. The microbiota synthesizes vitamins, including vitamin K and certain B vitamins. Through metabolic byproducts and signaling molecules, it influences energy harvest, fat storage, and systemic inflammation. The relationship between host and microbiota is dynamic and fragile. Disruption of this balance, termed dysbiosis, has been linked to inflammatory bowel disease, obesity, insulin resistance, and mood disorders. Antibiotics, while life-saving, can wipe out large portions of microbial communities, sometimes leading to overgrowth of pathogens such as Clostridium difficile. Diet profoundly shapes microbial composition. Fiber-rich diets support diversity and beneficial fermentation, while highly processed, low-fiber diets diminish resilience. Research into probiotics, prebiotics, and fecal microbiota transplantation seeks ways to restore balance, but these fields remain in development. The gut wall itself is a marvel of dual identity, both a site of absorption and a barrier. Enterocytes linked by tight junctions regulate what crosses. Specialized cells secrete mucus and antimicrobial peptides, creating protective layers. Immune cells reside just beneath, sampling microbial and dietary antigens to mount tolerance or defense. When this barrier breaks down, inflammation or infection may follow. Conditions such as celiac disease exemplify inappropriate immune responses to dietary proteins, damaging villi and impairing absorption. Inflammatory bowel diseases such as Crohn's disease and ulcerative colitis involve immune dysregulation in response to microbiota, leading to chronic inflammation. A clinical vignette brings these threads together. A patient presents with chronic diarrhea and weight loss. Examination reveals pallor. Laboratory tests show iron deficiency anemia. Antibody assays return positive against gluten-related antigens. Endoscopy reveals blunted villi in the small intestine. This constellation points to celiac disease, an autoimmune reaction triggered by gluten that damages absorptive surface. The red flag here is persistent diarrhea with weight loss and nutritional deficiency. Without timely recognition, complications such as osteoporosis or intestinal lymphoma may follow. Underlying this complexity is orchestration by hormones and nerves. Gastrin, secreted in response to food, stimulates acid production in the stomach. Secretin, released when acidic chyme enters the duodenum, prompts bicarbonate secretion from the pancreas, neutralizing acid. Cholecystokinin stimulates both pancreatic enzyme release and gallbladder contraction. Motilin coordinates peristaltic waves during fasting. The enteric nervous system, often called the second brain, organizes local reflexes. It can operate independently of the central nervous system, explaining why isolated gut segments continue peristalsis in laboratory conditions. At the same time, it communicates bidirectionally with the brain through the vagus nerve, forming the gut-brain axis. This axis extends beyond motility. Signals from microbiota travel through neural, hormonal, and immune pathways to influence mood, cognition, and stress response. Studies suggest correlations between dysbiosis and conditions such as depression, anxiety, and autism spectrum disorders. Though causal mechanisms are under investigation, the gut-brain dialogue represents a frontier linking digestion to mental health. Another clinical scenario illustrates barrier and microbial roles. A patient recently treated with broad-spectrum antibiotics developed severe diarrhea. Stool tests reveal toxins produced by Clostridioides difficile. Here, elimination of commensal bacteria allowed pathogenic overgrowth. The red flag is diarrhea after antibiotic exposure, especially if severe or bloody. Prompt recognition and treatment are essential to prevent complications such as toxic megacolon. Mechanistically, the gastrointestinal system can be seen as a multi-layered interface. Food encounters chemical processing, mechanical propulsion, microbial fermentation, selective absorption, immune surveillance, and neural coordination. Failures at any layer, enzyme deficiency, motility disorder, microbial imbalance, barrier breach, manifest as gastrointestinal disease. Success depends on integration. The gastrointestinal system embodies partnership. Digestion is not the achievement of human cells alone, but of microbial allies and coordinated defenses. Health arises from balance between cooperation and control, a balance easily disturbed yet resilient when nurtured. From this landscape of nutrients and microbes, the journey now turns to pharmacology, where medicines themselves become travelers through the same barriers and pathways, subject to absorption, distribution, metabolism, and excretion. Picture a pill resting on the tongue, then swallowed with a sip of water. To a casual observer, it disappears down the throat in seconds. Yet that small tablet now embarks on a journey across membranes, through blood, into organs, transformed by enzymes, and ultimately expelled. Pharmacology describes this voyage through the framework of ADME, absorption, distribution, metabolism, and excretion. It is through these stages that drugs move, change, and produce effects that vary dramatically from one individual to another. Absorption is the process by which a drug crosses barriers to enter circulation. For oral medications, this begins in the gastrointestinal tract. First, the pill disintegrates into smaller fragments and dissolves. The solution then contacts the epithelial lining of the stomach or intestine. Lipid-soluble molecules diffuse across cell membranes easily, while large or charged molecules require specialized transport proteins. Some drugs resist gastric acid and enzymes, others are broken down unless formulated with protective coatings. The stomach's acidic environment and variable emptying time influence absorption. Drugs absorbed in the intestine encounter bile salts that aid lipid solubility. Food delays or enhances absorption depending on the drug's chemistry. For instance, a high-fat meal may increase absorption of lipophilic drugs by stimulating bile secretion, while binding to calcium or iron may reduce absorption of others. Not all medications rely on the gut. Sublingual tablets dissolve under the tongue and diffuse directly into blood through oral mucosa, bypassing the digestive system. Rectal formulations exploit venous drainage that partly avoids first-pass metabolism in the liver. Injections deliver drugs directly into tissue or bloodstream. Intravenous administration with 100% bioavailability is used when rapid or precise delivery is needed. Bioavailability quantifies absorption efficiency. It is the fraction of an administered dose that reaches systemic circulation unchanged. Oral drugs may lose a substantial fraction to enzymatic degradation or first-pass metabolism in the liver. Two drugs with the same active ingredient may differ in bioavailability depending on formulation, a key concept in comparing generics and brand names. Once absorbed, drugs distribute throughout the body. The blood delivers molecules to tissues at different rates depending on perfusion. Well-perfused organs like liver, kidneys, heart, and brain receive drugs rapidly. Skin, fat, and bone equilibrate more slowly. Protein binding in plasma influences distribution. Many drugs bind albumin or other proteins. Only the unbound fraction can diffuse into tissues and exert effects. Competition for binding sites can lead to displacement and increased free concentrations, altering potency and risk. Fat solubility strongly affects distribution. Lipophilic drugs cross membranes easily and may accumulate in adipose tissue. They can be stored there for long periods and released slowly, prolonging action. Water-soluble drugs remain mostly in plasma and interstitial fluid. A particularly selective barrier is the blood-brain barrier. Endothelial cells joined by tight junctions and supported by glial cells limit passage of many substances. Lipid-soluble drugs and those with specific transport systems penetrate. Large polar molecules are excluded. This explains why many antibiotics cannot reach the brain in significant concentrations, while certain anesthetics act quickly on the central nervous system. Volume of distribution is a derived parameter expressing how extensively a drug leaves blood and enters tissues. A high volume suggests widespread tissue distribution, while a low volume suggests confinement to plasma. Understanding this guides dosing and interpretation of blood concentrations. Metabolism is the chemical alteration of drugs primarily in the liver, but also in intestine, lungs, and kidneys. Its goal is to make compounds more water-soluble for excretion. Metabolism occurs in two phases. Phase 1 reactions include oxidation, reduction, and hydrolysis. The cytochrome P450 family of enzymes is central here, adding or exposing functional groups. These modifications may inactivate a drug, activate a prodrug, or create active metabolites. Grapefruit juice famously inhibits some P450 enzymes, raising levels of certain drugs. Phase 2 reactions involve conjugation, attaching bulky groups like glucuronic acid, sulfate, or acetyl groups. This increases water solubility and facilitates renal or biliary elimination. Metabolism varies widely between individuals. Genetic polymorphisms produce fast and slow metabolizers. For example, some people metabolize caffeine rapidly, experiencing little effect, while others metabolize it slowly, leading to prolonged stimulation. Age, liver disease, and concurrent medications also alter enzyme activity. Drug-drug interactions occur when one drug induces or inhibits enzymes, changing levels of another. Excretion removes drugs and their metabolites. The kidneys play the primary role. Renal clearance involves filtration at the glomerulus, secretion into tubules, and reabsorption depending on solubility and urine pH. Water-soluble compounds are eliminated efficiently. Lipid-soluble drugs may be reabsorbed unless metabolized. Other routes contribute. Biliary excretion carries drugs into the intestine, where they may be reabsorbed in enterohepatic circulation or eliminated in feces. Lungs exhale volatile agents such as anesthetics. Sweat, saliva, and breast milk contribute small amounts. Renal impairment slows clearance, causing drug accumulation. Monitoring kidney function and adjusting dosing prevents toxicity. Hepatic impairment reduces metabolism, similarly prolonging drug action. Half-life describes the time required for drug concentration in plasma to fall by half. It reflects both metabolism and excretion. Drugs with long half-lives may require days to reach steady state or to be eliminated after stopping. Understanding half-life informs dosing intervals and duration of effects. Pharmacokinetics unifies ADME into mathematical models. A dose yields a concentration time curve, rapid rise with absorption, peak at maximum concentration, decline with distribution and elimination. First-order kinetics describe most drugs. The rate of elimination is proportional to concentration, so a constant fraction is cleared per unit time. A few drugs follow zero-order kinetics. Elimination proceeds at a constant rate regardless of concentration, leading to disproportionate accumulation at high levels. Steady state is reached when the rate of drug input equals output, typically after 4 to 5 half-lives. Therapeutic drug monitoring measures concentrations for drugs with narrow therapeutic windows, where small changes in level may cause toxicity or loss of efficacy. If pharmacokinetics is what the body does to the drug, pharmacodynamics is what the drug does to the body. Most drugs act by binding receptors, proteins that translate binding into cellular responses. Agonists activate receptors, mimicking natural ligands. Partial agonists activate receptors but produce less than maximal effect. Antagonists bind but do not activate, blocking the receptor from natural ligands or agonists. The dose-response curve maps effect versus concentration. Potency is the concentration needed for effect. Efficacy is the maximum effect achievable. Two drugs may differ in potency but achieve the same efficacy if given at sufficient dose. Receptor regulation modulates response. Prolonged exposure to agonists may cause downregulation, reducing effect over time. Chronic blockade may cause upregulation, increasing sensitivity when blockade ends. Tolerance and withdrawal reflect these adaptations. Not all drugs act through receptors. Some chelate metals neutralize acids or alter membrane properties directly. Others target enzymes, ion channels, or nucleic acids. Pharmacodynamics encompasses all such interactions, from molecular events to whole body outcomes. A patient takes a sedative at night but feels groggy the next morning. Pharmacokinetics explains prolonged effect, slow metabolism, storage in fat, or impaired excretion. Pharmacodynamics explains sedation through receptor activation in brain circuits. Together, they clarify variability. Another patient takes an analgesic but reports little relief. Enzyme induction from another medication may accelerate metabolism, reducing effective levels. Alternatively, genetic variation in receptor sensitivity may blunt effect. This variability reminds us that dosing must be individualized. Drug action is a dialogue. The body alters the drug through absorption, distribution, metabolism, and excretion. The drug alters the body by binding receptors or targets, producing responses. Variability arises from differences in barriers, blood flow, protein binding, enzyme activity, excretion efficiency, receptor density, and signaling pathways. No two individuals process a drug identically, explaining the wide spectrum of responses seen in practice. Medicines are not static chemicals but travelers. Their journey depends on terrain, membranes, barriers, enzymes. It depends on traffic, blood flow, protein binding, competing drugs. It depends on weather, genetic variation, age, organ function. Seeing drugs as travelers reduces mystery and encourages respect for complexity. From the voyage of drug movement, attention shifts naturally to safety. How to recognize when these travelers take wrong turns, collide with each other, or reach vulnerable passengers. Understanding adverse effects, interactions, and risks across populations forms the next chapter. Every therapeutic tool carries risk. Pharmacology is not only about how medicines achieve their intended effects, but also about how they can misfire, interact, or harm when used without vigilance. Drug safety begins with attention to adverse reactions, awareness of interactions, and recognition of special vulnerabilities across populations, such as pregnant women, older adults, and children. These layers of safety are not peripheral to pharmacology, but part of its essence, because the boundary between healing and harm is thin, and only careful practice keeps medicine on the right side of that line. Adverse drug reactions are unintended, harmful effects occurring at normal therapeutic doses. They can be anticipated or unanticipated. Predictable reactions arise from a drug's known mechanism of action. A blood thinner that reduces clotting inevitably increases the risk of bleeding. An antihistamine that blocks histamine receptors in the brain as well as in the nose causes drowsiness. These are extensions of pharmacological action into places or intensities where benefit turns into burden. In contrast, unpredictable reactions are not easily derived from mechanism but involve idiosyncratic host responses. Allergy is a prominent example. Here, the immune system treats the drug as a foreign threat, mounting responses that range from rash and itching to swelling of airways or, in extreme cases, life-threatening anaphylaxis. Distinguishing between side effects and true allergies is critical. A mild stomach upset after taking an antibiotic is unpleasant but not an allergy, while throat swelling and difficulty breathing after the same drug is a dangerous immune-mediated event. Drug interactions add another layer of complexity. One medication may alter the effect of another through multiple pathways. Absorption can be altered if one drug changes stomach acidity, motility, or binding. Distribution can be affected when two drugs compete for the same plasma protein binding sites, increasing the free concentration of one. Metabolism is especially important. Many drugs are substrates, inhibitors, or inducers of liver enzymes, particularly cytochrome P450 isonet. If one drug accelerates metabolism, the other may lose effect prematurely. If one inhibits metabolism, the other may accumulate to toxic levels. Excretion at the kidney can also be a site of competition. Drugs sharing transporters may block each other's clearance, raising plasma levels. Grapefruit juice is a familiar non-drug example. It inhibits a major metabolic enzyme in the intestine, raising blood levels of many drugs. Even common over-the-counter remedies or herbal supplements, often taken without disclosure, can meaningfully alter safety profiles when combined with prescribed therapy. Special populations highlight why uniform prescriptions are not possible. In pregnancy, drugs may cross the placenta and influence development, a phenomenon known as teratogenicity. Historical tragedies underline the importance of caution. Medicines once considered safe caused birth defects before systematic testing was required. Today, every prescription during pregnancy requires weighing maternal benefit against fetal risk, often with incomplete data. Older adults represent another vulnerable group. With aging, metabolism slows, kidney function declines, and fat-to-muscle ratio changes. These factors prolong half-lives and alter distribution. Moreover, older patients often take multiple medications, creating fertile ground for interactions. Children pose different challenges. Their enzyme systems are still maturing, and their organ volumes differ, so clearance and distribution patterns do not match adult norms. Dosing cannot simply be scaled by weight. Developmental stage must be considered. Monitoring is an active safeguard. Blood tests measure drug concentrations, kidney and liver function, or effects on blood cells. Therapeutic drug monitoring is essential for medicines with narrow safety margins, such as anticonvulsants or anticoagulants. Regular review of all medications, known as medication reconciliation, helps prevent accumulation of unnecessary or conflicting prescriptions. Pharmacovigilance programs at national and global levels collect reports of adverse events. Through these patterns emerge, a drug in wide use may reveal rare but serious complications only after years of accumulated experience, leading to warnings, restrictions, or withdrawal. A vignette illustrates these principles. A patient takes several medicines for high blood pressure, cholesterol, and arthritis. Frustrated by new back pain, they add an over-the-counter anti-inflammatory. Without consulting their clinician, within days they develop stomach bleeding. The interaction between anti-inflammatory drugs and blood thinners magnified bleeding risk. The red flag here is sudden passage of black stools, vomiting blood, or unexplained anemia in anyone using such combinations. Prompt recognition of these signs can prevent catastrophic outcomes. Mechanistically, many safety issues arise from imbalance between therapeutic window and biological variability. The therapeutic window defines the concentration range where benefit outweighs harm. Some drugs, such as those for seizures or certain heart conditions, have narrow windows. Small deviations above therapeutic concentration can produce toxicity, while small deviations below can cause loss of effect. Genetic variation complicates this further. Two individuals taking the same dose may achieve very different blood concentrations because of differences in enzyme activity. Some metabolize drugs too quickly, rendering them ineffective. Others metabolize too slowly, accumulating harmful levels. These differences explain why standardized doses sometimes fail and why personalized approaches grow in importance. Beyond pharmacology itself lies the principle of responsible prescribing. Clinicians must ask not only what a drug can do, but whether it must be used at all. Necessity, benefit, risk, and alternatives must be weighed carefully. Polypharmacy, use of many drugs simultaneously, should be avoided unless each medication is justified. Where possible, treatments are tapered and discontinued rather than accumulated. Patients must be educated on what to expect, which adverse effects require immediate attention, and which interactions to avoid. Safety is not a passive feature of drugs themselves. It is the result of active management of complexity by patients and clinicians together. Another case illustrates this. An older adult is admitted after a fall. Review shows they were taking medications for blood pressure, sleep, and bladder urgency. The sedative increased risk of confusion at night, while the bladder medicine caused dizziness. Together, these contributed to imbalance and fall injury. The red flag is a sudden fall in someone on multiple central nervous system acting drugs. Here the danger was not any single prescription but their cumulative burden. Safety also encompasses production and regulation. Manufacturing standards ensure purity, correct dosing, and absence of contaminants. Regulatory bodies evaluate clinical trial evidence before approval, but surveillance continues after drugs enter widespread use. Rare effects may only appear in 1 in 10,000 patients, detectable only through large-scale monitoring. Withdrawal of unsafe drugs, updates to labeling, and recommendations for restricted use reflect this ongoing vigilance. There is also a global dimension. In some setting, counterfeit or substandard drugs circulate, containing incorrect ingredients or inadequate concentrations. These not only fail to treat disease, but also foster resistance, especially in antibiotics. Strengthening supply chains and regulation is therefore a crucial part of safety. Mechanistically, safety can be seen as managing variance. Biology introduces unpredictable variability, genetics, comorbidities, diet, environment. Social practice introduces additional variability, access, adherence, misunderstanding, counterfeit supply. Safety systems aim to buffer these uncertainties so that the outcome remains within therapeutic boundaries. To view medicines with respect rather than fear is to recognize them as powerful tools. A hammer in a skilled hand builds, in careless use it wounds. Drugs are similar. Their value lies not in their intrinsic properties alone, but in the context of vigilance, humility, and responsibility with which they are applied. From the safety of drugs, attention now turns to the safety of patients in another dimension, the world of microbes. Understanding bacteria, viruses, and antibiotics equips clinicians to treat infection effectively without fueling resistance, a balance as delicate as any therapeutic window. That journey begins with the next chapter. A drop of sputum under a microscope, a smear stained with violet and red, can unlock an entire world of diagnosis. Microbiology for clinicians is not the whole field of microbial science, but a focused set of principles and tools that help distinguish, identify, and guide treatment of infectious diseases. The aim is not memorization of countless organisms, but a systematic approach. Recognize likely categories, confirm with simple tests, and use results to shape therapy while preventing harm. The first division is the gram stain, a century-old technique that remains a cornerstone. Bacteria are broadly separated into gram-positive and gram-negative based on cell wall structure. Gram-positive organisms retain the violet crystal dye due to thick peptidoglycan layers, appearing purple under the microscope. Gram-negative organisms lose the dye and take up a counterstain, appearing red or pink because their thinner wall is protected by an outer membrane. This simple distinction guides empirical antibiotic choices and narrows diagnostic possibilities quickly. Cocci, spherical and bacilli rod-shaped appearances add further resolution. For example, gram-positive cocci in clusters often indicate staphylococci, while gram-positive cocci in chains suggest streptococci. Gram-negative rods might represent Escherichia coli, Klebsiella, or Pseudomonas. Cultures extend this analysis. Specimens from blood, urine, sputum, or wounds are placed on nutrient media that favor bacterial growth. Colonies are observed for shape, color, and behavior, and further tested with biochemical reactions. A culture not only identifies the pathogen but also allows antibiotic susceptibility testing. The antibiogram. Discs impregnated with antibiotics are placed on a plate. Zones of inhibition reveal whether the organism is sensitive or resistant. This guides targeted therapy, reducing unnecessary broad-spectrum use that drives resistance. Viruses, lacking cell walls and not visible with light microscopy, require different tools. Detection often relies on molecular methods such as polymerase chain reaction, which amplifies viral genetic material. Serology can detect antibodies indicating past or current infection. For some viruses, antigen tests provide rapid bedside results, as in influenza or COVID-19. Culturing viruses is specialized and less common in routine practice. Fungi present another category. They may appear as yeasts, like Candida, which form smooth colonies and can cause infections in immunocompromised hosts, or as molds, like Aspergillus, producing filamentous growth. Special stains highlight fungal structures, and culture can confirm species. Parasitology adds further diversity. Organisms such as Plasmodium, causing malaria, or Giardia, causing intestinal infection. These are often detected by microscopic examination of blood smears or stool samples, guided by travel and exposure history. Infection prevention is as critical as diagnosis. Hand hygiene, protective equipment, and sterilization of instruments reduce spread within healthcare settings. Vaccination prevents specific infections, reducing overall burden. Public health surveillance tracks outbreaks and informs strategies. Resistance threatens these defenses. Overuse and misuse of antibiotics have accelerated the rise of resistant strains such as methicillin-resistant Staphylococcus aureus and multi-drug-resistant gram-negative bacilli. Clinicians now practice stewardship, prescribing only when indicated, using narrow-spectrum agents when possible, and completing full courses to suppress survival of partially resistant strains. A clinical sketch demonstrates the logic. A patient presents with burning urination and fever. Urine dipstick shows leukocytes and nitrites, suggesting bacterial infection. Urine culture grows gram-negative rods, identified as E. coli, susceptible to a narrow-spectrum antibiotic. Treatment is adjusted accordingly. The red flag here is fever with urinary symptoms, which may indicate ascending infection to kidneys, requiring prompt evaluation. Mechanistically, the interaction between microbes and host immunity shapes outcomes. The immune system constantly patrols, containing many exposures without symptoms. Infection occurs when microbial load or virulence exceeds defenses, or when host defenses are compromised by illness, medication, or age. Clinicians interpret tests within this context. A positive culture without symptoms may represent colonization, not infection. Misinterpreting colonization as disease can lead to unnecessary antibiotics, fueling resistance. Microbiology shows the power of seeing what is invisible. A stain, a culture, a PCR signal, each reveals a hidden partner in illness. Recognizing patterns among unseen actors trains you to respect both the small and the unseen in daily life. Respiratory infections are among the most common. Streptococcus pneumonia, a gram-positive coccus, remains a leading cause of pneumonia. Haemophilus influenza, a gram-negative coccobacillus, also contributes, especially in children and older adults. Viral infections such as influenza or respiratory syncytial virus spread seasonally with overlapping symptoms. Distinguishing bacterial from viral infection prevents unnecessary antibiotics. Cultures, antigen tests, or PCR can clarify the cause. Skin and soft tissue infections often arise from staphylococci or streptococci. Staphylococcus aureus causes boils, cellulitis, and abscesses. Methicillin-resistant strains complicate treatment, requiring careful antibiotic choice. Streptococcus pyogenes can cause cellulitis and, rarely, necrotizing fasciitis, a rapidly progressive infection requiring urgent surgical evaluation. Fungal skin infections like dermatophytes cause superficial but persistent disease. Urinary tract infections are typically caused by enteric gram-negative rods, especially E. coli. Simple infections may present with dysuria and frequency, complicated infections with fever, flank pain, or sepsis. Cultures confirm species and sensitivities. Recurrent infections invite investigation of structural or functional urinary tract abnormalities. Gastrointestinal infections range from viral gastroenteritis to bacterial foodborne illness. Salmonella, Shigella, and Campylobacter are common bacterial causes. Clostridioides difficile, often after antibiotic use, produces toxins that inflame the colon. Stool cultures or toxin assays guide diagnosis. Protozoa like Giardia or Entamoeba cause persistent diarrhea, often linked to contaminated water. Bloodstream infections represent serious systemic illness. Bacteremia may arise from urinary, respiratory, or gastrointestinal sources. Septicemia implies systemic inflammatory response to infection, with risks of shock and organ failure. Blood cultures are essential, taken from multiple sites before antibiotics when possible. Positive results guide therapy. Negative results do not exclude infection, especially if prior antibiotics were given. Neurological infections include meningitis and encephalitis. Bacterial meningitis may be caused by Neisseria meningititis, Streptococcus pneumoniae, or Listeria in certain groups. Viral meningitis is often milder, commonly from enteroviruses. Cerebrospinal fluid analysis with gram stain, culture, and PCR is crucial. The red flag is headache with fever, neck stiffness, or altered mental status, an emergency scenario. Resistance mechanisms illustrate microbial adaptability. Bacteria may produce enzymes that destroy antibiotics, such as beta-lactamases cleaving penicillins. They may alter target sites, pump drugs out, or reduce uptake through membrane changes. Genetic exchange spreads resistance. Plasmids carrying resistant genes can move between species. This is why stewardship emphasizes not only correct drug choice but also minimizing unnecessary exposure, as every exposure selects survivors with resistance traits. Viruses adapt differently, mutating rapidly due to error-prone replication. Influenza undergoes antigenic drift, small changes accumulating yearly, and antigenic shift, larger reassortments that can cause pandemics. HIV mutates under selective pressure, requiring combination therapy to prevent escape. Fungi develop resistance through alterations in target enzymes or efflux pumps. Immunization represents a triumph of microbiology applied clinically. Vaccines against measles, polio, hepatitis, pneumococcus, influenza, and many others prevent millions of deaths yearly. Herd immunity reduces circulation of pathogens, protecting those unable to be vaccinated. Continued development targets emerging threats like Ebola or novel coronaviruses. Hygiene measures remain fundamental. Clean water, sanitation, food safety, hand washing, and sterilization reduce exposure. In hospitals, infection control teams monitor outbreaks, enforce protocols, and track resistant organisms. These measures are often more powerful at reducing disease than any single antibiotic. A traveler returns from abroad with fever, chills, and sweats. Blood smear reveals ring-shaped parasites inside red cells, Plasmodium falciparum, the cause of severe malaria. Immediate treatment is life-saving. The red flag is fever after travel to endemic regions, particularly with altered consciousness or severe anemia. This highlights the global dimension of microbiology. Local patterns differ, and travel history is part of every evaluation. Microbiology illustrates cooperation as much as conflict. Many microbes live peacefully on skin and gut or in mouth, contributing to digestion, immunity, or protection against harmful invaders. Pathogens are only a small subset. The challenge is to discern friend from foe, colonization from invasion, harmless presence from dangerous proliferation. The clinical task is not elimination of all microbes, but restoration of balance. The unseen world thus shapes visible health. To learn its codes, gram stains, cultures, resistance patterns, is to learn how to decode illness with precision. From the world of microbes and their challenges, the next chapter steps into evidence itself, how to measure test accuracy, judge treatments, and safeguard patients with structured systems. Imagine a physician confronted with a new test for a serious disease. The manufacturer promises accuracy, yet promises alone cannot guide practice. Evidence-based medicine arose to provide a disciplined method of judging such claims, integrating clinical expertise with the best available research and patient values. Alongside it, patient safety initiatives remind us that even correct science can falter if systems allow error. Together, these frameworks form a protective net beneath the complex work of modern healthcare. Evidence-based medicine begins with questions. A test or treatment must prove itself against rigorous standards. Central to this proof are measures of diagnostic performance. Sensitivity describes the ability to detect disease when it is present, the proportion of true positives. Specificity describes the ability to rule out disease when it is absent, the proportion of true negatives. Neither alone suffices, both must be considered together. Predictive values add perspective. A positive predictive value tells us the probability that a patient with a positive result actually has the disease. A negative predictive value tells us the probability that a patient with a negative result truly lacks the disease. These values depend not only on test accuracy, but also on disease prevalence in the tested population. A highly accurate test may mislead if applied in the wrong setting. For example, testing a rare disease in a general population can yield more false positives than true positives. Likelihood ratios provide another lens. A positive likelihood ratio indicates how much a positive result increases the odds of disease. A negative likelihood ratio indicates how much a negative result decreases the odds. These ratios allow clinicians to apply Bayesian reasoning, updating prior probability with test results to reach a posterior probability, the most informed estimate of disease likelihood. Beyond tests, evidence evaluates treatments. Randomized controlled trials, where participants are randomly assigned to treatment or control, minimize bias. Blinding further reduces the influence of expectations. Systematic reviews and meta-analyses combine results across studies, offering stronger conclusions than any single trial. Hierarchies of evidence rank study types, but thoughtful interpretation always remains necessary. One particularly useful metric is the number needed to treat NNT. This is the number of patients who must receive a therapy for one to benefit. If a drug prevents one stroke for every 20 patients treated, its NNT is 20. The smaller the NNT, the more effective the treatment. Its counterpart, the number needed to harm NNH, quantifies how many patients must receive a therapy before one experiences an adverse effect. Balancing NNT and NNH illustrates the trade-offs inherent in every decision. A clinical vignette highlights the challenge. A patient with chest pain undergoes a new blood test advertised for rapid detection of heart attack. The test is positive. The clinician must ask, how sensitive and specific is the test? What is the prevalence of heart attack in this patient's age group? What do likelihood ratios suggest? Without this reasoning, a false positive could lead to unnecessary invasive procedures. The red flag here is reliance on unproven tests or treatments without robust evidence, a pathway to harm. Patient safety complements evidence by focusing on system design. Even when evidence guides choices, errors can occur in practice. Medication errors, misidentification of patients, surgical complications, and failures of communication are common causes of harm. Safety science borrows from aviation and engineering, emphasizing redundancy, checklists, and culture change. Checklists exemplify this approach. A surgical safety checklist ensures correct patient identity, procedure site, anesthesia preparation, and instrument counts. In intensive care, central line insertion checklists reduce infection rates dramatically. The power lies not in paperwork but in structured pauses that prevent overlooked steps. Human factors research shows that fatigue, distraction, and workload increase error rates. Systems must therefore account for human limitations, designing workflows that support attention and reduce reliance on memory. Standardization, alarms, and clear labeling are examples. Reporting systems capture near misses and adverse events, enabling learning rather than blame. Evidence demands humility no matter how confident intuition feels. Structured data may reveal bias. Safety demands vigilance, even when knowledge is sound. Process flaws can undo it. Together they remind us that science and systems must cooperate. To grasp sensitivity and specificity more fully, consider hypothetical numbers. A test for pneumonia has 90% sensitivity and 85% specificity. Applied to 1,000 patients where 100 truly have pneumonia, it will detect 90% of predictive but miss 10 false negatives. Among the 900 without pneumonia, it will correctly identify 765 true negatives but falsely label 135 false positives. Sensitivity reassures us that few cases are missed, while specificity reassures us that positives are mostly correct. Yet predictive values shift with prevalence. In a setting where pneumonia prevalence is 10%, most positive results will be true. In a setting where prevalence is 1%, false positives dominate. Thus, clinicians must always interpret results against background likelihood, not in isolation. Clinical reasoning often involves thresholds, probabilities at which the benefit of action outweighs harm. For example, if the probability of pulmonary embolism is very high, treatment may begin before confirmatory imaging. If probability is very low, no test is needed. Evidence-based medicine helps define these thresholds using outcomes data to align practice with patient welfare. Individual studies may be flawed by bias, selection bias, performance bias, or reporting bias. Systematic reviews attempt to mitigate this by comprehensive search, critical appraisal, and synthesis. Meta-analyses pool data statistically, increasing power and precision. However, they too can mislead if underlying studies are biased. Evidence appraisal therefore requires skepticism and transparency. Safety is not only about checklists but also about culture. A culture of safety empowers all team members to speak up, values transparency over blame, and learns from mistakes. Hospitals adopting such cultures see reductions in adverse events. Leadership commitment, open communication, and continuous feedback loops sustain this culture. Consider an intensive care unit. A patient requires insertion of a central venous catheter. Without safety measures, risks include infection, bleeding, or misplacement. With a checklist, sterile barriers, and ultrasound guidance, complication rates fall sharply. The red flag is any insertion performed without adherence to sterile technique, a preventable risk. Evidence confirms that bundled interventions, when consistently applied, reduce infection rates nearly to zero. Evidence-based medicine extends beyond individual care to public health. Vaccination programs, smoking cessation policies, and screening initiatives all rely on evidence of benefit, harm, and cost-effectiveness. Safety science also scales outbreak response plans, disaster readiness, and health system resilience, apply the same principles of redundancy, transparency, and learning from error. At its core, evidence-based medicine honors the patient. Decisions are not based on authority or tradition alone, but on transparent reasoning grounded in data. Patient safety honors trust, recognizing that those seeking care are vulnerable to both disease and the systems designed to treat it. Together they form a discipline of humility. Knowledge must be tested, processes must be safeguarded, and outcomes must be continually measured. The journey through evidence and safety prepares us for integration. To test understanding, consider 3 short clinical cases: chest pain, fever with cough, and abdominal pain, where reasoning weaves together history, exam, labs, imaging, and evidence. That integration forms the final chapter. Clinical knowledge finds its fullest meaning when applied to real human problems. Abstract principles, lab values, and imaging signs are important, yet they remain fragments until woven together in practice. To integrate, we turn to cases, not as puzzles to be solved once, but as windows into how clinicians balance uncertainty, evidence, physiology, and safety. 3 scenarios, chosen for their frequency and educational value, illustrate this integration: chest pain, fever with cough, and abdominal pain. Each demonstrates how history, exam, vital signs, laboratories, imaging, and reasoning converge. Case 1. Chest pain. A middle-aged patient arrives reporting pressure in the chest that began during exertion and eased with rest. The words themselves carry weight. Pressure, exertion, relief with rest, features suggestive of angina, ischemic pain from reduced blood flow to heart muscle. The clinician begins by exploring details: onset, duration, radiation to arm or jaw, associated symptoms like sweating or nausea, and risk factors such as smoking, hypertension, or family history. Vital signs provide the first objective anchor. Blood pressure may show elevation from stress or depression from shock. Heart rate may be fast with pain or irregular with arrhythmia. Oxygen saturation confirms whether hypoxemia is present. A low blood pressure with chest pain is particularly concerning, hinting at severe compromise. Physical examination adds nuance. Auscultation of the heart may reveal murmurs suggesting valve disease. Lungs may reveal crackles from heart failure. Peripheral pulses confirm circulation. Although no finding alone rules in or out ischemia, the combination builds a picture. Laboratory testing focuses on cardiac biomarkers such as troponin, released when heart muscle is injured. A rising pattern over hours confirms myocardial infarction. Electrocardiography records conduction and repolarization patterns, showing ischemic changes. Imaging such as echocardiography evaluates motion of heart walls and pumping efficiency. The clinician interprets results probabilistically. If chest pain is typical, SCG shows ST segment elevation, and troponin is elevated, the likelihood of acute infarction is very high. Immediate treatment is warranted. If findings are less clear, the probability is intermediate, and further imaging like coronary angiography may be needed. Other conditions mimic cardiac pain. Gastroesophageal reflux can cause burning discomfort, sometimes confused with heart pain. Pulmonary embolism can produce sharp chest pain and shortness of breath, diagnosed by CT pulmonary angiography. Aortic dissection can cause tearing pain radiating to the back, with blood pressure differences between arms, diagnosed by CT angiography. The red flag here is sudden severe chest pain with collapse or neurological signs requiring immediate emergency care. The reasoning sequence illustrates integration. Begin with history, refine with exam, anchor with vital signs, test with labs and imaging, and interpret using probability and evidence. Case 2. Fever and cough. A young adult presents with fever, productive cough, and shortness of breath. The clinician first clarifies onset, gradual or sudden, duration and progression, associated symptoms such as chest pain, rigors, or wheezing, refine hypotheses, exposure history matters, recent travel, sick contacts, occupational exposures. Vital signs again orient action. Fever indicates systemic response. Elevated respiratory rate signals stress or hypoxemia. Oxygen saturation provides objective evidence of gas exchange impairment. Low blood pressure with fever suggests possible sepsis. Physical examination targets respiratory system. Inspection may reveal labored breathing. Palpation may show reduced expansion. Percussion may reveal dullness over consolidation. Occultation may reveal crackles, bronchial breathing, or wheezes. These findings, though nonspecific, direct attention to lung pathology. Laboratory tests begin with blood counts. Elevated white cells with neutrophil predominance suggest bacterial infection, while lymphocytosis suggests viral cause. Inflammatory markers may support infection but are nonspecific. Blood cultures may identify bacteremia in severe cases. Sputum cultures can identify pathogens if sample quality is good. Imaging is decisive. Chest radiograph may show lobar consolidation, patchy infiltrates, or interstitial patterns. CT can reveal subtle disease or complications such as abscess or effusion. The clinician then matches findings to patterns. Lobar consolidation with fever and neutrophilia suggests bacterial pneumonia. Diffuse bilateral infiltrates may suggest viral pneumonia or atypical organisms. A clear chest radiograph with hypoxemia may raise suspicion for pulmonary embolism. Evidence guides decisions. Antibiotics are indicated for bacterial pneumonia with compatible features. Choice depends on local resistance patterns, allergy history, and severity. Supportive care includes oxygen, hydration, and monitoring. Safety systems, checklists for antibiotic stewardship, infection control precautions, prevent overuse and transmission. The red flag here is fever with rapidly worsening shortness of breath and low oxygen saturation, a signal of severe pneumonia or sepsis requiring urgent escalation. The case also teaches humility. Cough and fever are common, but interpretation depends on integration of history, exam, and tests. No single clue suffices, the story must be read as a whole. Case 3. Abdominal pain. A patient presents with diffuse abdominal pain, nausea, and vomiting. The clinician begins with history, onset, location, migration, intensity, relation to meals, and associated symptoms like fever, diarrhea, or urinary complaints. Past surgical history, medication use, and exposures add context. Vital signs show whether the patient is stable. Low blood pressure with rapid heart rate suggests shock. Fever suggests infection. Oxygen saturation and respiratory rate provide additional context. Examination is crucial. Inspection may reveal distension or scars. Auscultation assesses bowel sounds, hyperactive and obstruction, absent and ileus. Palpation tests for tenderness, guarding, or rebound pain, suggesting peritoneal irritation. Percussion assesses tympany from gas or dullness from fluid. Rectal or pelvic exam may provide essential information. Laboratory tests include blood counts, electrolytes, renal and liver function, and inflammatory markers. Amylase or lipase may suggest pancreatitis. Urinalysis may reveal infection or stones. Pregnancy testing is essential in women of reproductive age. Imaging follows suspicion. Ultrasound is useful for gallbladder disease, appendicitis, or gynecologic causes. CT abdomen provides broad overview for obstruction, perforation, or vascular causes. The clinician applies structured reasoning. Right lower quadrant pain with fever and leukocytosis suggests appendicitis. Epigastric pain radiating to the back with elevated lipase suggests pancreatitis. Right upper quadrant pain with positive ultrasound for gallstones suggests cholecystitis. The red flag is severe abdominal pain with rigidity, rebound, and shock, signs of peritonitis requiring urgent surgical evaluation. Again, the integration is evident. Structured history, targeted exam, careful vital sign interpretation, labs to refine, imaging to confirm, and probability-based reasoning to act. All three cases illustrate how systems interact. Chest pain reflects cardiovascular physiology and its failures. Fever with cough reflects respiratory defense and microbial invasion. Abdominal pain reflects gastrointestinal, renal, and vascular processes. Each case demonstrates interplay between history, physical exam, vital signs, labs, and imaging, guided by evidence and safety systems. Mechanistically, each case highlights how the body signals distress, ischemia through pain and biomarker release, infection through fever and inflammation, peritonitis through guarding and rigidity. These signals are not random, they reflect underlying physiology. Clinicians interpret them as languages, translated into probability and decision. Integration teaches patience with complexity. No case unfolds with perfect clarity. Data arrive in fragments, sometimes contradictory. The art is in weighting evidence, updating probabilities, and acting when benefit outweighs harm. Safety systems prevent error in this fragile balance, while evidence ensures decisions rest on more than tradition. From the cell to the system, from laboratory values to patient safety, the journey through medicine reveals interdependence. Knowledge is not a list of facts, but a web of relationships. The final lesson is that medicine is not about certainty, but about disciplined reasoning under uncertainty, always anchored in respect for the patient before you. And as the cases close, attention turns not to further analysis, but to rest. The body, like the mind, requires cycles of effort and release. To end, a simple rhythm: breathe in for 4 counts, hold for 7, breathe out for 8. This calming pattern mirrors the principles you have just studied: balance, integration, and steady rhythms sustaining life.